among the participants?
We'll start.
Yes. So before starting, I just wanted to ask some definitions with you people. So whomever is there can try to answer, unmute and answer. Can someone tell me what does a fluid bolus mean? Yes, someone?
500 ml in 30 minutes.
Okay. What does a fluid rush mean? Okay, it is nothing but it is in less than 30 minutes, very few minutes. You have to just rush the same 1 to 2 liters of fluid in few minutes. So, what does a preload mean? This you should answer. What does a preload mean? Someone? Hello, don't sleep. One of you
Volume of
answer.
blood in the ventricles at the end of the diastole.
Okay, okay. So, if this is preload, then what does fluid responsiveness mean? Okay, so that is what we are going to see. So we are going to cover today some of the important topics. Two different sessions will be done by me and Srihari, and tomorrow the rest of the cardiovascular system will be continued. So my topics would be hemodynamic monitoring in ICU and cardiac output monitoring in ICU. Like there are many questions which has been asked recently in the last DRNB question paper. Also, there was non-invasive cardiac output monitoring was one of the question. So just try to understand. If there is any doubt, please put in the chat box. We'll help you out definitely. So coming on to the major definitions, what is fluid responsiveness? Whenever you give a fluid challenge, you are giving a fluid challenge to the patient. When you see an increase in the cardiac output more than or equal to 10% after a preload incrementation by manipulation of venous return in a dynamic test context. So basically, when you give a preload challenge, you see an increase in the cardiac output more than or equal to 10%. So that word is very important. When you see the change in the cardiac output, not by BP, not by urine output, but you have to have a real-time cardiac output monitoring. Okay, so usually we see this fluid responsiveness when we are resuscitating a patient. So when we find that the patient is fluid responsive by a cardiac output change when they are hypoperfused, you use this test for a serial assessment, dynamic assessment. But sometimes you should not think in a normally euvolemic patient, you should not think just because they are fluid responsive, you cannot keep on giving fluids. So the patient should have a tissue hypoperfusion, and whatever fluid you are challenging, that should have some effect on their perfusion status. Right. So coming on to fluid tolerance. So whatever challenge we are giving, is the patient able to tolerate? What does tolerance mean? It is the degree to which a patient can tolerate administration of fluids without causing any organ dysfunction. So does that mean that all fluid unresponsive patients are fluid tolerant? Can fluid responsive patients be fluid intolerant? Can fluid responsive patients be fluid intolerant? Is that possible? Can one of you answer? Okay, so even if the patient is fluid responsive, he could be fluid intolerant because it doesn't depend on the challenge alone. It depends on the patient's underlying organ function also. If the patient is having a poor LV function or patient is having a CKD, he could not tolerate much of a fluid, but he could be fluid responsive, but the organ may not allow it to be as much as responsive in a normal patient. Okay, so fluid tolerance is the degree to which a patient can tolerate the fluid without causing any organ dysfunction. What is fluid overload? It is a state of global body accumulation of fluids after resuscitation with a deleterious impact on organ dysfunction. So this does not come in the early phases of resuscitation. This is usually after resuscitation. Once we find this, we have to start deresuscitation. So this is the picture what I was telling you. When you resuscitate, when you do give a preload challenge, there are two, this is a spectrum. So the patient could have hypovolemia, the patient could have fluid overload. So the patient could be fluid responsive, that is by with the change in the cardiac output, he could be fluid unresponsive. At the same time, the patient could be tolerant to fluid by taking up the fluid, resolution of the condition, responding. He could be intolerant, causing organ dysfunction and further worsening of the condition. So, when we talk about fluid responsiveness, we must mandatorily know what is Frank-Starling law, right? So, what is a Frank-Starling law? As we all know, can one of you tell me what does Frank-Starling curve represent normally?
Ventricular function depending on the preload.
Yes. So how much ever the ventricle can stretch at the left when at the end diastolic volume, that much good will be the contractility, right? So usually at the steep part of the Frank-Starling curve, the patient will be fluid responsive, considering the normal LV function. I mean, the LV function is normal, but if the patient have a poor LV function, underlying cardiac issues, then that response may not be seen like in a normal patient. So when we talk about hemodynamic monitoring, the common parameters which we monitor is cardiac output, it could be stroke volume, the common clinical parameters like heart rate, SBP, diastolic BP, MAP, or with volume based indices, or with pressure based indices, or it could be static indices, or it could be dynamic indices, right? So these are all the common hemodynamic parameters which we normally use in ICU. So what does a static hemodynamic parameter mean? What does static hemodynamic monitoring mean? Can one of you answer? Okay, so you give a preload challenge to a patient and you're seeing the response. Okay, so it is like a single time response that you are giving a preload and you are assessing the response. It is a single time assessment where you don't see the dynamicity as well as what are the changes that are happening inside the heart with the mechanical ventilation, heart lung interaction, nothing. You are just giving a preload, you are checking the cardiac output change and done. We are measuring it as a single one. What is dynamic one? You give a preload challenge and you're really seeing how does the system change according to the preload challenge, in especially in a mechanical ventilated patient, or you are giving a modified fluid challenge by means of passive leg raising or end occlusion test. So you are giving a preload challenge and seeing the system change, and there is a dynamicity, it is a continuous monitoring, so that is called dynamic monitoring. Static is like a single time monitoring. Okay, some of the static hemodynamic parameters could be pressure based, like central venous pressure, pulmonary artery occlusion pressure, or it could be volume based, like the end diastolic volume, LV end diastolic volume, RV end diastolic volume, global end diastolic volume, or it could be pressure based, as I told you. Dynamic parameters would be pulse pressure variation, that is with the heart lung interaction you are giving a preload challenge, how does the change happen dynamically. So some of the parameters in dynamic ones are pulse pressure variation, stroke volume variation, systolic pressure variation, pleth variability index, aortic blood flow peak velocity, and echo IVC distensibility, IVC collapsibility indices. Some of the common hemodynamic monitors which we use in our ICUs, the named ones are, commonly used ones are FlowTrack, Litco, Pico, Volume View, and Echo. Coming on to the static method. So all the static methods depend on the relationship between the venous resistance, the systemic filling pressure, and the right atrial pressure. So based on this, you give a preload, whether there is a preload responsiveness is there or not, it will be determined. So as I told you, it could be pressure based or it could be volume based. But when we think about static parameters, we usually assume many things. Rather than a reality, we assume many things. I will tell you, when we come to PAOP, we assume that the valves are, we assume that the pressure will be equal to volume. We assume that one chamber pressure or one chamber reflection is a reflection of all the other chambers. So many assumptions usually come when we think on static parameters. Okay, so the first parameter which we were discussing was central venous pressure. So it is mainly a preload index of right ventricle, but to a lesser extent of left ventricle too. It mainly principles in the end diastolic central venous pressure equalizes consecutively to the end diastolic pressure in the right ventricle, and so finally to the left ventricle. Okay, so usually a catheter is placed in the superior vena cava near the right atrium junction. So the CVP has three waveforms, as you all know: A, C, V wave with two descents. So the common point where we measure the central venous pressure is that R wave of the ECG, that is the C wave. And if suppose that could not happen, then you can measure the pressure at A wave. If that is also not possible, then you can measure at Z point, that is the pressure which corresponds to the end of the QRS complex. So what does it suggest? When it is low, it indicates that the right-sided preload is low, so the patient could be fluid responsive. When it is high, we think that the right-sided preload is high, so the patient may not be fluid responsive. So as per this yearly goal-directed therapy and all, in sepsis, the CVP value of 8 millimeter mercury was targeted. Right. The main disadvantage is that as per so many studies, as per literature, it had lower accuracy for predicting fluid responsiveness. At the same time, whenever there are major changes in the intrathoracic pressure, you are giving high P, or there are changes in the intra-abdominal pressure which are transmitted to the thorax, then the values could not be considered exclusively for the right atrium. It could be a reflection pressures from other in and around structures also. Coming on to pulmonary artery occlusion pressure. As I told you, we are assuming many things. So what is the goal here? We are inserting a catheter into the pulmonary artery, and we are assuming that the pulmonary artery catheter is in the west zone 3 of the lung, and we are occluding that particular point, and we are presuming that mitral valve is normal. So whatever pressure is reflected from the left side of the heart at that particular point gives us the function of the left side of the heart. Okay, but what if the mitral valve is not normal? What if there is a mitral stenosis? And what if that intrapleural, intrapericardial pressures are not normal? What if the pulmonary catheter is not properly placed? So there are many assumptions here when we are using pulmonary artery occlusion pressure as a reflector of fluid responsiveness. Even as per literature, the pulmonary artery occlusion pressure had not shown a significant difference in the fluid responders, non-responders of the fluid administration. Coming on to volume based indices. So as we know, all the volume based indices we'll have to use echo, like the left ventricular end diastolic volume, right ventricular end diastolic volume, all that with the help of echo, or you can use the PICO, whatever monitoring we had mentioned before. So the one of the volume based indices are global end diastolic volume and the derived global end diastolic volume index. So it estimates the blood volume of all the four chambers with the technique of transpulmonary thermodilution. So we need a central venous catheter and a tipped arterial catheter for this. So when we measure this global end diastolic volume or the index, it is an evaluation of preload and the stroke volume, because it estimates the volume in all the four chambers in the heart. Okay, so for this, the venous capacitance as well as the heart chambers compliance should be normal. So if you see this picture, the global end diastolic volume measures the blood volume in all the four chambers of the heart. Okay, so it is usually derived with the formula intrathoracic thermal volume minus pulmonary thermal volume. I will explain this better when we are discussing about the transpulmonary technique. Coming on to the next static parameter, that is IVC, which we use ultrasound, bedside ultrasound to measure. So it is nothing but any change in the diameter of the inferior vena cava in relation to preload. Right. If it is highly compressible or distensible, then we believe that the patient could be fluid responsive and we give a challenge. So usually the ultrasound at a determined length from the right atrial cavity during the end expiration we have to measure. But what are the problems if you don't get a proper window because of obesity, or if the patient is having lung hyperinflation, pneumothorax, or increased intra-abdominal pressure, then this measurement could be confounding. So normally in a spontaneously breathing patient, we measure collapsibility index, which is nothing but Dmax minus Dmin by Dmax into 100. So any value more than or equal to 50%, 40 to 50% are considered to be fluid responsive. Less than 40, then they are not fluid responsive. But in a mechanically ventilated patient with the tidal volume of 8 to 10 ml per kg, which is a baseline requirement, which you should remember, we measure distensibility index, that is Dmax minus Dmin by Dmin into 100. Any value more than 18%, the patient is considered to be fluid responsive. Any value less than 16% is considered to be non-fluid responsive. If we can also use other IVC measure, that is the delta IVC, which has a formula of Dmax minus Dmin by Dmax by plus Dmin by 2, that is the mean value into 100. Any delta IVC value of more than 12% is fluid responsive. Any delta IVC value of less than 12% is not fluid responsive. So these are the static parameters we saw. So we saw what is the definition of a static parameter, and then we divided it into a pressure based and a volume based indices. So pressure based ones are CVP and pulmonary artery occlusion pressure, and the volume based indices which we usually monitor with the devices, the proper devices, flow track, PICO volume view. Those are the end diastolic volumes of the ventricles and the total end diastolic volume, and then IVC. Now coming on to dynamic parameters. So we are giving a preload challenge and we are assessing the system change along with the preload challenge, how the system is responding to the preload. So the common parameters which we told are stroke volume variation, pulse pressure variation, systolic pressure variation, and IVC distensibility index, aortic blood flow velocity, and plethysmographic variability index. So this is a table which gives us the formula for each, which you can go through. Now coming on to important points with the dynamic parameters. Okay, the major baseline requirement of dynamic parameters is that the patient should be having minimal respiratory effort, like sedated, paralyzed, minimal respiratory effort, number one. Number two, the patient should be at least maintained on 8 to 10 ml per kg of tidal volume. Number three, the patient should not have any baseline cardiac arrhythmias. There should not be major right ventricular failure, and patient should have a normal abdominal pressure or any pressure confounding factors which could affect the pressure values. So if all these baseline parameters are fulfilled, that is when you can use a dynamic parameter. Okay, so the common problem with the pulse pressure variation is that when the patient does not have all these baseline parameters, then we may not be able to use the pulse pressure variation. But it is a very simple technique to use. Any diagnostic value, any pulse pressure variation of more than or equal to 15% is a better predictor of fluid responsiveness. Then comes stroke volume variation. Any value of more than or equal to 15% indicates a fluid responsiveness. Whatever baseline problems we had for pulse pressure variation applies here also. And there is a test called end expiratory occlusion test, which is one of the modified fluid challenge test, where you assess the change in the cardiac output. If there is any change more than or equal to 5%, then it is fluid responsive. Coming on to tidal volume challenge. For example, now the patient is on 6 ml per kg of a tidal volume. Now you increase the tidal volume to 8 ml per kg of tidal volume. You see the pulse pressure variation. If there is a variation of more than or equal to 3.5%, then they may be fluid responsive. Coming on to IVC distensibility, which we have discussed in detail, where if in any changes distensibility index of more than or equal to 12%, then the patient could be fluid responsive. Coming on to modified fluid challenge test. If suppose we are not giving any external preload, but we are using an internal preload, that is a modified fluid challenge to see the cardiac output change in the patient. So those are all passive leg raising, end expiratory occlusion test, some of the common modified fluid challenges test. So we will see everything in detail next. So passive leg raising, where you transfer a volume of approximately 300 ml of venous blood from the lower body towards the right heart. So it mimics a fluid challenge. So when you do this, it should be done over a period of 30 to 90 seconds, but it can be done in a spontaneously breathing patient, even in a patient who's having arrhythmias, even in a patient who are having low tidal volume ventilation, a poor lung compliance. In all such patients, this passive leg rising can be used. But only limitation is that you always need a real-time cardiac output monitoring, and any changes in the abdominal pressure which could affect the which could like may not prevent us to do the passive leg raising. Okay, so how do we do this PLR test? So first you keep the patient at semi-recumbent position, that is at 45-degree, that is your baseline, and then you tilt the patient from the 45-degree to the flat, where you use a real-time cardiac output monitoring to see the baseline cardiac output, and then you hold it for 30 to 90 seconds and bring back the patient to the the primary position, where you see these changes in the cardiac output, and if any changes more than or equal to 10 to 12%, you consider it as a significant cardiac output change, and the patient could be considered a fluid responsive patient. Then coming on to mini fluid challenge test, and in passive leg raising, if suppose you don't have a real-time cardiac output monitor, the other alternatives which you can use for passive leg raising is that one is VTI, that is the iotic VTI, which I'll explain you next. You can also use an end tidal carbon dioxide change. If it is more than or equal to 5%, it can be considered as fluid responsive. You can use a perfusion index, which usually is seen in the monitors. Anything more than or equal to 9%, they are considered as fluid responsive. You can also use pulse pressure variation, stroke volume variation, the ratio. If it is anything more than or equal to 1 to 4 points, then the patient could be fluid responsive. And you can also use capillary refill time with passive leg raising. Not much data on this, but anything more than or equal to 27%, the patient could be considered as fluid responsive. So these are the other methods in a passive leg raising which you can use in place of cardiac output monitoring if you don't have the real-time monitoring. Coming on to next dynamic test, that is the mini fluid challenge test. That is 100 ml of colloid you give over 1 minute. It is easy to perform bedside, but only thing is that you need a cardiac output monitoring device. Any changes of more than or equal to 5%, they are considered as fluid responsive. So coming on to iotic VTI, which we were telling before, it is an echocardiographically obtained measure of area under the velocimetric curve within the left ventricular outflow tract, or rather the distance traveled by the column of blood cells through the tract during the ventricular systole, which therefore allows us to have a stroke volume measurement. So you see a 5-chamber view. You find out the iotic, that is the left ventricular outflow tract, that is the iotic valve position, and then you use a pulse Doppler. And then at the end of expiration, you measure the velocimetric curve. The normal values are considered to be 18 and 22 centimeters. Any value lower than this are an index of reduced cardiac output. So usually you take an average of 3 measurements, while at least 5 is the best in case of atrial fibrillation. An increase in the VTI greater than or equal to 15% is considered a positive response to the filling. So if it is done by a single performer, more better. If suppose you are using passive leg raising or a mini fluid challenge, even 10% increase is considered to be fluid responsive. It can be done at the bedside, and it is a rapid and easy time consuming method. So you select a 5-chamber view in the echo, transthoracic echo, where at the aortic valve you put the pulse wave Doppler, and you will be finding this velocimetric curves which is running, where you trace the velocimetric curve and press measure, where you in the monitor you will get the VTI. So you have to measure the baseline VTI, and then by giving any fluid challenge, you use a passive leg raising, or you are giving a fluid challenge, or you are giving a mini fluid challenge, whatever you are using, you use a preload challenge, and then you see the change in the VTI. So from the baseline, if there is any increase from 10 to 15% is considered to be fluid responsive. Then coming on to SVC collapsibility index, where we need a trans-esophageal echo for this, where you keep the probe near the caval point where you find the SVC, IVC RA junction, where greater the increase in the greater the collapsibility index, greater the cardiac output will be after a preload challenge. So if the patient's basic collapsibility index is less than 39.4%, then the patient may not be fluid responsive. So this is another modified challenge which I was talking to you about. This is the end expiratory occlusion, like how we normally measure the intrinsic PEEP at the end expiratory occlusion, right, at the end expiratory point, right? So again, you keep you assess the patient's cardiac output at the baseline, and then you perform the end expiratory occlusion like when measuring intrinsic PEEP. At least 15 to 30 seconds you have to hold on, and then you measure the cardiac output change. So if there is a change in more than 10 to 15%, then the patient is fluid responsive. So this overall covers the hemodynamic monitoring. Static we have seen. Dynamic, the main important things you have to remember is when you have to think on dynamic parameters, what are all the baseline characteristics the patient should have, and what are all the methods we are using, and their advantages and disadvantages. An aortic VTI could be asked as a question. Passive leg raising is always asked as a question. So these are the dynamic parameters. Now going on to the next topic, that is cardiac output monitoring. So till now we were discussing about fluid responsiveness using static and dynamic measures. Now we are going to discuss about cardiac output monitoring. So as we know, what is cardiac output? It is the volume of the blood ejected from each of the ventricle per minute. So what are the determinants of cardiac output? It could be afterload, it could be contractility, it could be preload, it could be heart rate. So anything which changes the heart rate, like a sympathetic tone, exogenous sympathomimetics, any rhythm devices, arrhythmias, could affect the cardiac output. Anything which changes the preload, like the volume status, PEEP, intra-abdominal pressure, arrhythmias, compliance of the ventricle, could affect the cardiac output. Anything which affects the afterload, like outflow tract resistance, pulmonary or aortic resistance, peripheral vascular resistance, as high as hematocrit, could affect the cardiac output. Anything which affects the contractility could affect the cardiac output. So why do we measure the cardiac output? So whenever there is a deranged cardiac function in the context of shock, and goal-directed resuscitation of a multifactorial shock states. So in order to titrate fluids, inotropes, vasopressors, we usually measure the cardiac output. In case of depressed cardiac function, like perioperative or in a cardiac surgical patients, we usually do continuous monitoring of the cardiac output. And if you are planning on a protocol driven management of an hemodynamically unstable patient, you have an algorithm to follow based on cardiac output in a shock state, then that is when we use cardiac output monitoring. So when we classify these principles or the methods of measuring cardiac output, it could be based on principle, it could be based on invasiveness, non-invasiveness. So I will discuss both. So based on principles, how are we dividing the methods of cardiac output measurement? The primary basic fixed principle, or it is arterial waveform analysis techniques, or it is transthoracic impedance and bioreactance techniques, or it could be Doppler principle, or it could be indicator dilution techniques like thermodilution, transpulmonary or pulmonary, or pulse dye densitometry, or lithium dilution technique. So this is the classification of cardiac output monitoring based on the principles which we use basically. And the second way of classifying the methods are based on the invasiveness. Invasive, it could be pulmonary artery catheter using a pulmonary thermodilution technique. It could be intermittent or it could be continuous. Coming on to minimally invasive technique, where we just use a arterial line, where we use a pulse wave analysis, or we use a transpulmonary technique by using a CVC and arterial line. It could be any of that. So minimally invasive could be pulse wave analysis like flow track, pico plus, litco plus, volume view, or it could be Doppler trans-esophageal echo. Okay, and non-invasive would be like partial gas rebreathing, it could be bioimpedance, it could be bioreactance, it could be transthoracic echo, it could be ECOM. So this is the second way of classifying the cardiac output monitoring methods. Coming on to invasive ones, that is the pulmonary artery catheter. So we saw that previously pulmonary artery occlusion pressure can be used as one of the dynamic parameters of fluid responsiveness, but as per literature with fluid responsiveness there is not much of a difference. So when we use it as a cardiac output monitoring, it is like one of the gold standard where we use a fixed principle, and where we see we put the catheter indwelling crossing all the chambers of the heart, where we can see the real time changes with the oxygenation consumption, as well as arterial and venous difference of the oxygen as per fixed principle, right? So it is considered one of the gold standard technique. But coming to evidence like Pacman trial or FACT trial in ARDS or ESCAPE trial in heart failure patients, there is no major superiority found with pulmonary artery catheter monitoring techniques compared to other techniques. Okay, so this is one of the invasive method of cardiac output monitoring, where it uses fixed principle. That is, it is based on a formula VO2 by CaO2 minus CvO2 into 100. That is oxygen consumption and the difference in oxygen content between the arterial and the venous side. This technique is called pulmonary thermodilution technique. So all we need is a PA catheter. So the cardiac output is mainly determined by the flow pressure curve by means of the baseline patient characteristics, as well as the waveform which we are going to get at the end of the dilution technique. So what you're going to do, you're going to inject a 10 cc of 10 degrees Celsius of saline through the catheter into the right atrium, and you're going to look for decrease in the blood temperature when the cold saline passes through the heart chamber. So a thermodilution curve will be plotted by connecting the catheter to a computer. Thermodilution is nothing but what is the change in temperature of the blood when you give a cold saline when it passes across the heart. That's all. So whichever thermodilution curve which you are getting, any area under this curve is inversely proportional to the flow rate in the pulmonary artery, which is determined by the cardiac output of the right ventricle. What are the limitations that could happen? There could be loss of injectate, there could be temperature variations, there could be technical problems with the device, there could be vascular problems like a clot formation which could happen, there could be inaccurate measurements because of any of the valve problems or any of the track problems when we pass in the pulmonary catheter. And the common complications which we face are catheter related problems. There could be pulmonary artery rupture, embolism, there could be infective catheter related problems or damage to the cardiac valves, and the use should be usually limited to 48 hours and to a maximum of 72 hours only. So as I was discussing with you, we are using a fixed principle and we are using the thermodilution technique. So where we are using a formula called modified Stewart-Hamilton equation. So we are getting a thermodilution curve. So the area under the curve is inversely proportional to the flow in the pulmonary artery, right? So we can see that. So the pulmonary artery curve, we have got two curves now. So the greater the cardiac output, faster the dilution, smaller the area under the curve. Okay, so the smaller the curve, the greater the cardiac output. That is how you measure. So this is usually an average value where we take 2 to 3 values to a maximum of 5 values, and then based on the patient baseline characteristics, the monitor gives us the cardiac output. Okay. So hope you understood the pulmonary artery catheter. It works. It is in one of the invasive method. It works on the principle of fix, and we are using pulmonary thermodilution. We are injecting a cold saline and seeing the changes with the temperature of the blood over the chamber, and we are getting an area under the curve which is inversely proportional to the flow in the pulmonary artery, which gives us the cardiac output. Coming on to minimally invasive techniques, where we need a CVC, where we need a arterial line, but it functions on a transpulmonary thermodilution. That means you are giving the cold or whichever the low temperature solution in the heart, but you are measuring the effect in the periphery, either through the central line. You are measuring it via the arterial line. So this could use multiple techniques. Transpulmonary thermodilution is one. There could also be pulse contour analysis, and you have to calibrate these devices. Meaning, see, you are first time it will measure a cardiac output, right? So it will take that first value as the reference cardiac output value. So it will keep on sending a loop feedback telling that this is the baseline value, you have to bring it back to this value. And then whenever you are increasing the noradrenaline, whenever you are giving a fluid bolus, whenever you are adjusting the device, that time and all, you have to manually calibrate the device to the baseline value. That is called calibration. So cold through the central vein cannula, and the blood temperature changes through a thermistor located at the arterial catheter. So the calibration should be done every 8th hourly, or whenever there is hemodynamic instability, you have to do it much more frequently. So what are all the values we are going to get apart from the cardiac output? So we are going to get the intrathoracic blood volume, global end diastolic volume, and extravascular lung water, PVPI, that is pulmonary vascular permeability indexes. So these are the other secondary values which we are going to get along with the cardiac output monitoring. So what are the limitations? So if there are any changes with the arterial resistance, then there could be issues with cardiac output monitoring. Technical, like device related problems, air bubbles, clots, or if there is any valvular issues, or significant arrhythmia in a patient, or presence of an IABP, or if the patient is less than 40 kg, or if there is any rapid change in the temperature, then it may not reflect the correct cardiac output values. So the common complications would be obviously vascular complications and catheter related complications. So as I told you, we are using a CVC and a arterial line, and you are injecting the cold saline through the CVC, and you are seeing the change at the arterial level where there is a thermistor which sees the thermodilution techniques. Now, bit in detail, just to make you understand what are the terminologies mean. So we saw that it is a thermodilution technique, transpulmonary thermodilution techniques. So obviously there will be a thermodilution curve, right? So the cardiac output is calculated by the area under the curve, which we already discussed. So there are two transit times here. One is that the mean transit time, which indicates half of the time it takes for the cold indicator to pass through the chambers. Okay, and there is a down slope time where it is a time which tells us when the temperature comes back to the baseline. So whenever you multiply this mean transit time with a unit cardiac output measurement, you get the intrathoracic thermal volume. That is nothing but the time taken for the cold saline to travel through all the chambers of the heart. Okay, so it gives us the overall change in all the chambers, that is intrathoracic thermal volume. Okay, so now the downslope time, that is the temperature comes back to the normal. Why it is important? Because in a chamber, in general, in a chamber, whenever the blood volume is more inside the chamber, the temperature drop will be earlier and quicker, right? So here, when you multiply the cardiac output, that is volume per unit time cardiac output, into the down slope time, you get the volume of the largest component, that is the chamber with a higher blood volume, where the dilution happens very quickly. Here it is pulmonary thermal volume. Okay, the largest chamber which we are considering here is the pulmonary thermal volume. So when you subtract these two, that is the intrathoracic thermal volume minus pulmonary thermal volume, that is when you get the global end diastolic volume. Okay, so what is intrathoracic thermal volume? It is the time taken for the cold saline to pass through all the chambers. What is pulmonary thermal volume? It is the time that is taken for the temperature to return back to normal, because the volume in this compartment is very high, where the dilution happens very fast. You can see in this curve, the drop in the curve is very fast, right? So that is the pulmonary compartment. So when you subtract these two, you get the global end diastolic volume, which I told you I will explain in this chapter. So pulmonary blood volume has two different divisions. One is the actual pulmonary blood volume and the extravascular lung water, usually where the heat exchanges happen. So by measuring this extravascular lung water in this cardiac output monitoring devices gives us so many clues about what type of edema a patient could have. Right. So we have two indices when we are measuring a cardiac output in the PICO or a volume view. We will also get other indices as we discussed, like all these thermal volumes, all these GDV and extravascular lung water index and pulmonary vascular permeability index. So what is the importance of the other indices which we commonly see with the cardiac output monitoring? So this could be asked as a short note. So extravascular lung water index, it is nothing but, as we saw, in the pulmonary thermal volume, what is the water content in the lung? So the normal value is 3 to 5 ml per kg of the predicted body weight. 6 to 7 ml per kg of the predicted body weight. If suppose the patient is having a higher extravascular lung water index, like 8 to 10 ml per kg, then there could be mild edema. If the patient is having 11 to 12 ml per kg, then there could be gradually increasing edema. As the value increases, we believe that the pulmonary edema is severe. What is pulmonary vascular permeability index? This is nothing but an indirect indicator of how the vessels in the lungs are. For example, in ARDS, the basic pathophysiology is that there will be leaking capillaries in the pulmonary vessels. So if this index is more, we believe that it is mostly an ARDS, like a non-cardiogenic pulmonary edema. So the normal value is that is less than 1.7. Anything more than 2.85 gives us a clue that it is a non-cardiogenic pulmonary edema. So extravascular lung water index tells us how bad is the hydrostatic edema. Pulmonary vascular permeability index tells us how bad is the vascular edema, that is because of the permeability issues. So the potential limitations could be, there could be underestimation in cases of PE, or when the patient is having PEEP, or there is pulmonary vasoconstriction or inhomogeneous ARDS. Overestimation could happen in case of pneumonectomy, PEEP, low cardiac output states, recirculation or intracardiac shunting. So with these two indices, when we have a ratio, that is extravascular lung water by pulmonary blood volume ratio, gives us the pulmonary vascular permeability index. So as if any value is more than or equal to 2.85, tells us it is a non-cardiogenic pulmonary edema. Coming on to, so we saw the minimally invasive technique. The one is the transpulmonary thermodilution. The second method we are coming on to is that pulse wave analysis. So the pulse wave analysis allows estimation of the cardiac output based on continuous analysis of the arterial blood pressure waveform and a complex physiological signal determined by an interplay of left ventricular stroke volume, systemic vascular resistance and the vascular compliance. So it could be invasive, it could be minimally invasive, it could be non-invasive. In pulse wave analysis, again, we have subtypes. So it could be an externally calibrated system, or an internally calibrated system, or it could be an uncalibrated system. So basically it is nothing but analyzing the pulse. Okay, so as I told you, it could be invasive, externally calibrated, minimally invasive, internally calibrated, uncalibrated, non-invasive, internally calibrated. So the externally calibrated one is the one which we use in PICO, nothing but transpulmonary thermodilution technique, where we are going to use area under the curve, under this pulse wave analysis curve, and you are going to tell the cardiac output. Whereas coming on to the minimally invasive, the pulse wave is going to get analyzed at 2000 hertz or at multi-level, or based on the patient characteristics. Along with the pulse wave analysis, we are going to derive a cardiac output. In case of non-invasive ones, where you are just measuring with the baseline values and the waveform characteristics. So as I told you, there could be 3 or 4 methods under the pulse wave analysis how we get the cardiac output. So number one, area under the curve is the one which we used in PICO and volume view. And there could be pulse power analysis as we see in LITCO. There could be dynamic tone technology, which like in FlowTrack or Vigilio. So basically we are analyzing the pulse in multiple waves, multiple forms. So as I told you, it could be calibrated, internally calibrated, externally calibrated, uncalibrated. So FlowTrack calibrated, it usually calculates the cardiac output and the stroke volume variation with the patient's artery waveform, as well as with the baseline characteristics of the patient. All we need is an arterial line. And then in LITCO, which uses this pulse power technology, it could be calibrated version, internally calibrated version, externally calibrated version. So both use changes in the mean blood pressure related to stroke volume, and the whole of the arterial waveform will be analyzed. Another technique is that PRAM, which is pressure recording analytic method, where it analyzes the pulse and divides it into a systolic phase and a diastolic phase by identifying the dicrotic notch. And based on the waveform characteristics, it tells us about the nature of the resistance which it could see in the artery and the cardiac output. So LITCO is one of the common methods which we use. That is why I had put. So what you are doing in LITCO, it is like kind of an indicator dye technique. Instead of a cold saline, you are using a lithium here. That's all. So you are injecting the lithium into the venous component, and you are measuring that lithium at the arterial component with a sensitive sensor. So basically it measures the area under the curve, the stroke volume variation, and then it gives us the cardiac output. So the limitations would be patients who are undergoing lithium therapy or any neuromuscular blocker which has a quaternary ammonium component, which could disturb with the function of the electrode. And other problems which could affect the reading in LITCO is that aortic insufficiency, IABP, damped arterial wave, post-aortic surgery, in arrhythmias or shunting problems. So as I told you, we are giving a bolus of lithium, we are sensing it in the arterial end, and finally it measures the change under the change of the lithium across under the curve, and then we are measuring the value. Coming on to PRAM, as I told you, it divides the arterial waveform into pulse waveform into systolic and diastolic by identifying the dicrotic notch. So it measures the signal at the frequency of 1000 samples per second. The normal curve will be this, and at various arterial resistances, the curve characteristic changes. So it not only gives us the indirect cardiac output monitoring, but also tells us what could be the underlying cause for the cardiac output change by different waveform characteristics. So coming on to transesophageal echo. So in minimally invasive, we have seen the transpulmonary technique, we have seen the pulse wave analysis technique. Now coming on to transesophageal echo. So it is nothing but inserting a Doppler into a probe, and this Doppler probe is inserted into the distal esophagus by means of TE technique, and it usually measures the blood flow in the descending aorta at 35 to 40 centimeters from the incisors. So it monitors and calculates the cardiac output using the descending aorta diameter, which is either obtained from an age-related nomogram or measured directly in the newer machines. So the ventricular ejection time corrected for the heart gives us the indication of preload. The peak velocity rate gives us the estimation of contractility of the ventricle. So the common, I'll come to that. So as I already told you, this esophageal Doppler is nothing but doing a TEE and seeing the flow in the descending aorta, right? So there is an ultrasonic wave which which is going to sense the blood flow in the descending aorta, and it is going to give us the cardiac output. So it is based on the Doppler principle. What is the Doppler principle? A Doppler shift in the frequency occurs when the ultrasound wave is reflected back from the moving RBCs with the shift in frequency proportional to the velocity of the blood flow. Okay, so basically it uses the Doppler principle, and by reflection of the ultrasonic waves from the moving RBCs, using this formula, it gives us the cardiac output. Okay. Manipulate the probe until the characteristic Doppler signal is found, that is equal to distribution of RBC velocities at a given point in time. So what could be the limitation? Whenever the flow in descending aorta is low, which contains only 70% of the total blood flow, it is necessary to add a corrector to compensate for the aortic arch. And whenever there is aortic coarctation, aortic aneurysm, in the presence of IABP, there could be difference in the flow measurement. Accuracy could also be affected by changes in the pulse pressure, any vascular issues, any volume status, or use of the inotropes. So what are the parameters we are measuring in the transesophageal echo? Number 1, cardiac output we are getting. Number 2, stroke volume using the Doppler formula. Number 3, we are getting a corrected systolic flow time, which is the one which is going to indicate the preload. The normal value is 0.33 to 0.36 seconds. So the interpretation of corrected flow time and the peak velocity gives us the afterload value. Then comes the peak velocity. It indicates the contractility. The normal range is age related. Normally between 20 years, it will be around 90 to 120 centimeters per second. And at 90 years, the flow will be reduced like 30 to 60 centimeters per second. So interpretation of this corrected flow time and the peak velocity, as I told you, it gives us the idea about afterload. What are the advantages? So it is minimally invasive, quickly inserted, little training is required, and various age group probes are available. But it may make the patient require need for the sedation. There could be user dependent changes in the Doppler, the values. The probe may detect other vessels. It may be contraindicated in esophageal varices. So as I told you, the common things which we are finding in the transesophageal echo is that a stroke distance, a mean acceleration point, and a peak velocity. So the flow time gives us the idea about the preload, and the peak velocity gives the idea about contractility. So when you use this both, you will get the idea about afterload. Same. So the probe is inserted at the level of descending aorta, where the ultrasonic wave reflected from the moving RBCs is reflected as the waveform. And the cardiac output is calculated using this formula. Like the VTI, as we saw in that aortic VTI, it has a velocimetric curve into the heart rate, and the cross-sectional area of the aorta gives us the cardiac output. Along with that, the peak velocity, the corrected flow time gives us individual components like the preload, the afterload, the contractility. Coming on to non-reactive methods, non-invasive methods. So in this we have NICO, bioimpedance, bioreactance, and the peripheral methods. So what is NICO? So we saw the fixed principle, that is which uses the oxygen consumption and the difference of oxygen at the arterial and the venous side. That is like a direct indicator. You are putting a pulmonary catheter, you are taking the mixed venous blood from the pulmonary vessel, you are taking the arterial blood from the arterial vessel, and you are directly calculating the fixed principle. So it is a direct one. So this is kind of an indirect fixed principle. Nothing but instead of oxygen, we are using a carbon dioxide as an indicator for cardiac output by going less invasive, meaning non-invasive. So we know that normally, so basically in stable phase, the carbon dioxide enters the lungs through the lung arteries, which is proportional to the cardiac output and is equal to the output of the lungs and the lung phase. So initially, what you're going to do is, you're going to, in an intubated patient, you're going to measure the end tidal carbon dioxide, which is assumably equivalent to the carbon dioxide consumption, and which is assumably equal to the arterial content of the carbon dioxide. Okay, so now you are making the patient's baseline value with the EtCO2 values. So we have a carbon dioxide consumption, that is VCO2, and we have a arterial carbon dioxide value through the arterial blood, and we have one baseline character parameter. Okay, now we have to find the venous content of the carbon dioxide. How we are going to find that? We are going to connect a rebreathing circuit to the patient's ET tube, where the patient is not going to exhale the carbon dioxide, but he is going to rebreathe the carbon dioxide. Okay, so what will happen eventually? The carbon dioxide content in the alveolar side, the venous side, is going to increase, right? So that particular value for a transient period of time is assumed to be the CVCO2 value. So we had the baseline VCO2 value and a CaCO2 value. Now we have got the CVCO2 value. Okay, so by means of rebreathing, you are just increasing the carbon dioxide content on the venous side and the alveolar side, which you are taking the value as CVCO2. So once you have all the values, it is nothing but a fixed principle, and then you calculate the cardiac output. Okay, so this picture depicts the same. So you have a baseline characteristics for 60 seconds, and then you make the patient rebreathe for 50 seconds, and then you close the valve again. So the patient starts breathing to the baseline. So with this difference in the cardiac output as an indirect indicator of fixed principle gives us the cardiac output value. But limitations would be, we have to place a chip with the ventilator constant settings. It may not be possible with patients with chest trauma, intraperitoneal shunt, or a high cardiac output status, or low ventilation. In such cases, there could be inaccurate measurements. So coming on to the next non-invasive method, that is transthoracic echo. So how are we going to measure the cardiac output with the transthoracic echo? So we need to calculate only two values. Number one, left ventricular outflow tract area. In a parasternal long axis view, you are going to zoom in the left ventricular outflow tract, and you are going to measure the left ventricular outflow tract in centimeters. So using this formula, you are going to calculate the left ventricular outflow tract area. Then second one, we are going to calculate left ventricular outflow tract VTI, which we already know. Like you put at the 5-chamber view, where you put the Doppler wave at the aortic opening, and you see the velocimetric curve. So you got a VTI. Now you have a LVOT area, and you have the VTI. So which is going to give us the stroke volume. Stroke volume is nothing but left ventricular outflow tract area into left ventricular outflow tract VTI. When you multiply this with the heart rate, you're going to get the cardiac output. So this is one of the non-invasive bedside measures which we can use for cardiac output monitoring. Coming on to other non-invasive methods, bioimpedance, bioreactance. So both these principles are based on, we are keeping few electrodes on the chest, and we are seeing that the lung, the heart, all as a conducting tissue. So these conducting tissues senses the motion of the blood flow within these pressure chambers, and this motion sensing is going to get detected in the electrode, which is going to reflect as using an algorithm inside the machine. It is going to give us the cardiac output value. So electrodes 6 in number are placed across the patient's thorax as innermost and outermost electrodes, and the tissue fluid volume, pulmonary and venous blood volume, aortic blood volume, all contribute to the bioimpedance. So changes in the cardiac output will change the amount of the aortic blood, and it will be reflected in the bioimpedance. So the stroke volume is usually calculated as the volume of the electrically participating tissue and the ventricular ejection time taken from RR interval, and the ejection phase contractility index, which is indirectly proportional to the bioimpedance. I don't think this formula you have to remember, but just the concept, if you remember, is more than enough. Like basically the volume inside the chambers, the conducting tissues, all these motion sensors, the electrode is sensing based on an algorithm, it is giving us a cardiac output. So limitations could be, there could be electrocautery interference, patient movements, obesity, pleural effusion, because there is an extra fluid which is going to be sensed, arrhythmias, sternum wires, that's external wires which could interfere with the electrical activity of the impedance. So as I told you, there are innermost electrodes, there are outermost electrodes, which senses the motion of the blood using the electrical concept as well as the motion concept. Based on algorithm, we are getting the cardiac output. It is the same in reactance also. It is just a modification of the impedance, which avoids the interferences by noise and the external sources. It analyzes the changes in the phase of electrical voltage signal to the current applied across the thorax. So changes in the electrical capacitive and inductive properties occur secondary to the changes in the intrathoracic volume. Again, 2 electrodes are placed, and the changes across the electrodes gives us the cardiac output. The main advantages are we can use it in intubated patients, even in arrhythmias, even in operating rooms. The next device we are using is that endotracheal cardiac output monitoring device, that is called Ecom, where that ET tube itself is special, because the cardiac output here is measured by a plethysmography of impedance. So the electric current passes through the electrode on the body of the endotracheal tube. Okay, and the change in the second impedance to the aortic blood flow will be received by the electrode on the cuff. So there is an electrode on the cuff along the body of the ET tube. So the first change would be when the electric current passes through the ET tube, and the second impedance will be sensed by the electrode in the cuff. So as it lies parallel to the blood flow, it detects the changes in the blood flow across the aorta, which gives us the plethysmographic curve, which gives us the stroke volume and cardiac output changes. Next device, non-invasive method is that photoelectric plethysmography. So in this method, there are 2 things. One is a volume clamp technique, and the second is that photoelectric plethysmography, where you see that there are 2 things. One is that plethysmographic sensor, which is going to detect the volume of the blood passing through the finger on the limb. And the second is that the cuff, which is tied, it is going to continuously give pressure to get a arterial blood pressure waveform. Okay, so if you see this picture, there is a cuff tied across the finger, where there is an external pressure tonometer is being applied, and you can see that a BP waveform is being created. So based on the pressure applied, a BP waveform is created. So this plethysmographic sensor at the tip of the finger senses the blood flow. So there is a indicator for blood flow, and there is a blood pressure waveform. With that, with the baseline patient characteristics, it detects the cardiac output and the stroke volume. So it measures the pulse pressure using a photoelectric plasticization combined with the volume clap technique. The probe, which contains the light source, that is the PPG, a detector, is at the fingertip. There is a cuff which maintains the constant flow of the blood in the arteries, which gives us the waveform. So after analyzing these pressure, the blood pressure is calculated by the algorithm of the device, and the cardiac output is calculated using the waveforms and the blood flow which is sensed by the PPG. So limitations could be low cardiac output states, the peripheral blood flow could be impaired, which may not give us the actual value. The last non-invasive method is called pulse wave transit time analysis, where the cardiac output is derived on the principle of an inverse correlation between stroke volume and the pulmonary wave transit time. So what is pulse wave transit time? It is the time from the ECG R wave peak to the pulse wave rise point, which is defined as the point where the differentiated pulse wave reaches a 30% of its peak amplitude. So from the R wave, so this is the pulse wave which we are seeing, pulse oximeter wave. This is the radial artery pulse wave, and this is the ECG wave. So it is the time from the ECG R wave peak to the pulse wave rise point. R wave peak to the pulse wave rise point. Okay, this is this length of the time which we are measuring, where this period is divided into 3 phases. One, there is a pre-ejection phase, that is from the R wave to the rise of the aortic root pressure wave. And the second point is that the T1 phase, that is through the elastic artery, which is the time from the rise point of the aortic root pressure to the rise point of the radial pressure wave. And there is the third component, that is T2 at the peripheral arteries, which is the time from the rise of radial artery pressure wave to the rise of the pulse oximetry pressure wave. So we are gradually going from aorta to the radial artery to the peripheral pulse oximetry wave, where we are measuring the transit times from the R wave to the periphery. So variations in these values can be used to calculate the stroke volume and the cardiac output using the formula. So that's all about the pulse wave transit time. So these are all the various cardiac monitoring methods, cardiac output monitoring methods. If you have any doubt, please put it in the chat box. Now, next we will go to infective endocarditis, which is a short topic. Share screen. Yes. Can you see the screen?
Yes, it was a bit.
Okay, okay. So the next topic is infective endocarditis. So infective endocarditis is nothing but infection of the endothelial lining of the heart. Usually either it could be lining of the heart, it could be heart valves, or there could be a mural thrombi over which a secondary bacterial deposition is there. Infective end arteritis is that infection of the endothelial surface of any blood vessel, abdominal aortic aneurysms, AV fistulas, or prosthetic grafts. So what are the risk factors for infective endocarditis? Cardiac factors, given that there is a problem with the valve. There could be bicuspid aortic valve, mitral valve prolapse, or rheumatic valve disease, or congenital heart disease, or previous infective endocarditis episodes, or implanted cardiac devices like pacemakers, ICDs, CRTD devices, the leads, and prosthetic heart valves. Coming on to comorbidity risk factors, if the patient is using intravenous drug abuses, chronic kidney disease, chronic liver disease, malignancy, which could cause the marantic embolies, advanced age, corticosteroid use, poorly controlled diabetes, or any indwelling line is there, or an immunocompromised status. These are the common risk factors for infective endocarditis in whom we have to suspect. Coming on to classification, it can be classified as acute if it is less than 2 weeks, where the patient might present with a fulminant infection. There could be abrupt onset of fever, leukocytosis, systemic toxicity, sudden onset of heart failure, MOTS, and death. Subacute, anything more than 2 weeks, insidious in onset, non-specific symptoms spanning between weeks to months. The second classification would be based on a native valve, that is if the patient is having a bicuspid aortic valve or a prolapsed valve which is causing the issue, RHD which is causing the issue, or it is a prosthetic valve which you have placed is causing the issue. Early prosthetic valve infections are less than 12 months following surgery, late ones are more than 12 months following surgery, or it could be in patients who inject drugs, what could be the changes, or nosocomial infective endocarditis like VAP, like a CLAPSI, any patient who has been hospitalized more than 72 hours into the tertiary center with the baseline risk factors which we discussed before, or acquisition of infective endocarditis in association with a significant invasive procedure performed during a recent hospitalization less than 8 weeks before the onset of the symptoms. Either way, it is nosocomial. Or intravascular foreign body related, as we discussed, because of pacemakers, ICDs, leads, all that. Coming on to etiology. The microbiological organisms which are involved commonly in infective endocarditis are Staphylococcus species, Streptococcus species, most commonly the viridans ones, and the Enterococcus species, and very rarely we may have a gram-negative aerobic bacilli in case of nosocomial ones, in case of this indwelling devices ones, fungal in case of immunocompromised patients, the miscellaneous bacteria like Hake organisms, Neisseria, Pseudomonas, Legionella, there could be polymicrobial, and sometimes it could be culture negative also. So I have given 3 to 4 tables based on in which conditions which all organisms could be suspected. I mean the common ones we have discussed, but the rare ones you can just go through the charts in the pre-recorded classes where in individual conditions which organism we should suspect based on the AHA recommendation. You can just go through the charts where when we should suspect a gram negative one, when we should suspect a coagulase negative one. It is a quite an extensive chart. Please go through. Coming on to pathophysiology. Normally when there is a normal endothelium resistant to pathogen is being invaded by a bacteria. So bacterial adhesion happens in a patient with underlying risk factors. Once the bacteria adheres, there could be there is an inflammatory response which will lead to thrombogenesis. On the top of that, there could be vegetation formation. This is the basic pathophysiology of the infective endocarditis. So how are we going to diagnose? So primarily clinical, because the Duke's criteria has the minor criteria with the clinical factors also. So even if the major is not positive, then you have to know the clinical features of infective endocarditis. And mainly microbiological and echocardiographical, which forms the major criteria of the Duke's criteria. So clinical plus echocardiography plus microbiological, out of which micro and echo are the primary and clinical is one of the minor. And other phenomenons like in a patient with infective endocarditis with end organ embolic phenomenons, immunological phenomenons, that could be one of the indirect evidence of infective endocarditis. So the clinical features which is commonly seen in infective endocarditis are the constitutional symptoms like fever, malaise, pyrexia of unknown origin for a prolonged duration of time more than 2 weeks, and then on examination, clinically there could be fever, there could be arthralgia, there could be this skin lesions, and on examination wise there could be cardiac murmurs, again lesions, there could be rod spots, there could be hematuria, which all the complications of the infective endocarditis end organ embolic phenomenons. So as I told you, they can present with various clinical features, just constitutional symptoms or vascular or immunological phenomenon based on the underlying clinical condition. So in 2023, the Duke's criteria had been modified a little, where they had included this not only the echocardiography but also other imaging modality, and even if you find infective endocarditis or the vegetation in open cardiac surgery during the inspection during the cardiac surgery, then that is also one of the major criteria. So these are all the some changes which has been made in 2023 Duke. The major criteria is that 2 or more positive separate sets of blood cultures for organisms typical for endocarditis like Staphylococcus, Streptococcus, Enterococcus, which are the most common ones, or 3 or more positive separate sets of blood cultures for organisms that rarely or occasionally cause endocarditis. Okay, so the primary thing is that at least we have to send 2 or more positive separate blood cultures. Second is that the PCR or nucleic acid techniques that identifies Coxiella burnetii, Bartonella species, Trophairema vipili from the blood, or serological evidence of Coxiella burnetii is positive. And indirect immunofluorescence assays which detects the antibodies to the rare organisms. So this is one microbiological major criteria which it should be positive to diagnose an infective endocarditis. Coming on to imaging, previously there was only echo, now these are included. Echocardiography or a cardiac CT showing vegetation, valvular leaflet perforation, aneurysm, abscess, pseudoaneurysm or a fistula. or echocardiography showing significant new valvular regurgitation, or worsening or changing of the pre-existing is not sufficient, but you should have a new valvular regurgitation or a new dehiscence. Then there should be PET CT, FDG PET CT showing abnormal metabolic activity involving the native or a prosthetic valve or an ascending aortic graft or intracardiac device leads or any other prosthetic material. And surgical evidence of infective endocarditis observed on a direct inspection during a cardiac surgery. These are the major criteria. Coming on to minor criteria, any predisposing risk factors the patient is having, like previous history of endocarditis, there is a prosthetic valve repair, congenital heart disease, more than mild regurgitation or stenosis of any etiology, or any implantable device is there, or patient is having a HOCM, or there is a drug abuse, IV drug abuse history. And along with that, if the patient is having febrile episodes more than or equal to 100.4, along with a vascular phenomenon or an immunological phenomenon, then these forms the minor criteria, along with minor imaging and microbiological criteria, that is the CT showing the same pickup of abnormal metabolic activity. And if echocardiography is not advisable, then auscultatory evidence of new valvular regurgitation could be considered. And microbiological in a minor criteria is that blood culture showing organism consistent with infective endocarditis, or any of the other PCR antibody techniques which you can use for identification of the organisms. Coming on to echo. So we always have this question, when to do a transesophageal echo, when to do a transthoracic echo. So 2015 there was a AHA guideline, 2016 there is a European guideline which says that you suspect an endocarditis, you do a transthoracic echo. That is a primary thing which you have to do. But based on the guidelines, there is a difference with the transesophageal echo. That is, transthoracic echo should be done as soon as the endocarditis is suspected as per both the guidelines. But TEE, if TTE is not diagnostic in patients in whom suspected infective endocarditis is there, then you do a TEE. But if complications are suspected, like a new murmur, embolism, persisting fever, heart failure, abscess, AV block, then you do a TEE. But repeat TEE when you have to do. As per AHA, it should be 3 to 5 days later after the treatment, and as per European guidelines, it is usually 7 to 10 days after the primary TE. So as per the flow chart, you are clinically evaluating based on Duke's criteria and the risk factor. You are diagnosing the infective endocarditis, and you do of the transthoracic echo. If suppose you could not find anything major in the transthoracic echo, or a doubtful finding, or if the patient is suspected to have any complications of the infective endocarditis, like an embolic phenomenon, heart failure, valvular issues, then you go ahead and do the TE. And after that, you can use the ancillary testing like the CT testing, this FDG testing to confirm the diagnosis and treat. So these are the other serology markers which we can use for diagnosing infective endocarditis, which is bit advanced, where you can see the table in the pre-recorded class. Coming on to management. So the management would include, of course, it is an infection. You have to treat it with an antibiotic. That is the first step. Then you have to see what are all the possible complications could occur with the end organ and support the organ. And number 3, because the patient is having a valvular issue, because there is a thrombus or a vegetation which could become an emboli, right? So there is always a question like when to start the antithrombotics in them, right? That is the third aspect of the treatment. Number 4, when to refer the patient for the surgery, whether we should wait for a few weeks after the antibiotic, or there are indications to refer them to the surgery. So these are the 4 aspects of the treatment when it comes to infective endocarditis. So the first step is antibiotic. So before diagnosing, the initial empirical antibiotic therapy is that you cover staphylococcus, streptococcus and enterococcus, where usually it is covered by penicillin. If they are penicillin susceptible organisms, you can use ampicillin, cloxacillin, ceftriaxone or a vancomycin plus gentamicin until the pathogen is identified. Once you identify the pathogen by blood culture, the common combination is that ceftriaxone plus gentamicin. If it is a streptococcus in a native valve endocarditis, you continue for 4 weeks. If it is a prosthetic valve endocarditis, you continue for 6 weeks. Whereas in a staphylococcal infection, you have to use the staphylococcal antibiotics like the flucloxacillin, oxacillin. Those are the antibiotics. The flucloxacillin based regimen you can use, or cefazolin based, vancomycin based regimen also can be used, but it should be continued for 4 to 6 weeks. Whereas in prosthetic valve, you either use flucloxacillin or vancomycin plus gentamicin and rifampicin to be added in a prosthetic valve. It should be continued for 6 weeks. In enterococcus, again penicillins plus gentamicin or ceftriaxone plus ampicillin can be used for 6 weeks. Whereas in a prosthetic valve endocarditis, same combination for 6 weeks. In a culture negative, it should be based on the epidemiological factors and which organisms are very common, or is there any indwelling device. Based on the epidemiological factors and the infectious disease report, we have to treat as per our hospital protocol. So I have put in 3 to 4 tables based on AHA guidelines and European guidelines. Overall, it is the same. But based on sensitivity, for example, this MIC values based on penicillin sensitivity or vancomycin resistance enterococcus, what are all the alternate options? Like in a detailed manner, there are 3 to 4 tables based on the AHA guidelines I have put in. Please go through. But overall, the combination is ceftriaxone plus gentamicin in a native valve, ceftriaxone plus gentamicin and a rifampicin in a prosthetic valve in case of streptococcus. Staphylococcus, you use the cephalococcus plus gentamicin, and in rare organisms, the Hague group of organisms, you use as per your hospital protocol. So if the patient, so the duration of therapy is approximately 4 to 6 weeks. If the patient improves clinically, you can definitely switch them to a oral therapy consisting of same penicillins, linezolid, moxifloxacin in case of streptococci. In case of staphylococci, you can try levoflox, linezolid, septran, dicloxacillin plus rifampicin if the patient is able to tolerate orally. These are the some of the antibiotics, like a step down approach from the IV if you are putting them for 6 weeks on home discharge. So coming on to the antibiotics, always been divided into definitive as well as prophylactic. Prophylactic though we don't handle much, but as per recent guidelines, when you are suspecting there is highest risk of infective endocarditis in a patient who are undergoing dental procedure or any mucosal manipulation or a vaginal mucosal manipulation, then you may have to subject them to the prophylactic antibiotic therapy when they have a risk factor. Okay, coming on to surgical intervention. So again, as per European and AHA guidelines, there are some differences, but primarily, when are you going to refer a patient with an infective endocarditis for surgery? So when the patient is having heart failure, when the patient is having an uncontrolled infection, despite of treating with a definitive antibiotic, you are not seeing any response and causing more and more intracardiac complications. And when it is causing an embolism risk, where the embolism is growing up between 10 to 30 millimeter and it is getting disseminated to brain, heart and kidney. So the common indications compared to European and American are the same, but coming on to European, they refer the patient for surgery when the vegetations are more than as big as 30 millimeter mercury, but AHA, it refers to surgery when it is even 10 millimeter mercury. Okay, so these are the AHA and European guidelines. The early surgery is indicated when the patient is having heart failure, severe heart failure, or an uncontrolled infection in form of abscesses, relapsing infective endocarditis, or highly resistant organisms like fungi or multi-drug resistant gram-negative organisms. Then you have to refer them for surgery. And if embolic phenomenon is seen with a vegetation of more than 10 millimeter mercury, then you are going to refer them to surgery with prior 2 weeks of antibiotic continuation. Coming on to antithrombotics. So whether we should use or not use. So based on a recent meta-analysis conducted by Caldanzo in 2024, where they compared antithrombotics in infective endocarditis patient. So where they observed there was a lesser in-hospital mortality in patients whom antithrombotics were used, and lesser systemic thromboembolism in whom antithrombotics were used, but cerebrovascular events, intracranial hemorrhage events were more or less the same in both the groups. So finally, what is the conclusion? You have to see the baseline patient's condition. You have to put it into a multidisciplinary team with the neurology, cardiology, and patients who are already on warfarin therapy based on their coagulation profile, coagulopathy parameters. You have to have a multidisciplinary approach to start the antithrombotics. But if possible, you can start, because as per the study, we can see that the mortality as well as the complications are less. But always it depends on a baseline patient's clinical scenario and a multidisciplinary approach. So as a overall gist, when you suspect infective endocarditis clinically, you apply Duke's criteria, you go on to the microbiological criteria as well as echo criteria, you start them on an empirical antibiotic, and you start them with a culture sensitive antibiotic, and whichever thing is causing the infective endocarditis, like a prosthetic valve or a material like a pacemaker, ICD, try to remove it after treating with the antibiotic. Then the follow-up imaging as per guidelines, it could be TEE or FDG, CT or an MRA, and then continue the antibiotics for 6 weeks and look for complications. So this is how the gist of infective endocarditis goes. Thank you. Any doubts, please put in the chat box. I will reply. Thank you. So the next speaker will take over. Yes, I can see the slides here. Yes, yes.
Good evening to everyone. So the first two discussions that Bhuvaneshwari had presented were on hemodynamic monitoring and cardiac output and infective endocarditis. So important things to note is that infective endocarditis is the high potential theory question that needs to be noted. And since the Duke's updated criteria has come, definitely there is a high probability that that can come as a question. So it is important to know about it. And hemodynamic monitoring and cardiac output. In the last October 2023 session, there was a question on non-invasive cardiac output monitoring methods that was asked as a detailed question. So it's a high scoring area. If you know about it well with the diagrams and algorithms, there are more chance of getting better marks related to those topics. So my talks for today will be on VA ECMO, cardiac pacing, and defibrillators. So from a theoretical aspect, VA ECMO has higher priority than the other two topics. And from a theoretical point of view, though previously there have not been many questions asked, there are high chances that they can be asked in the upcoming sessions, especially in relation to comparison of various mechanical circulatory devices in relation to LV venting, indications, contraindications, weaning from ECMO, and decannulation. So these areas are some few things that you need to keep in mind. And from a practical perspective, that is for your practical exams, if at all an ischemic heart disease case is kept with heart failure, there are very, very high chances that they're going to go into ECMO. So you need to know about it. And in practical, in the equipment section, they can keep various ECMO cannulas for discussion. So that also needs to be kept in mind. So I'll go into the topic proper. So I'll be covering mainly the exam perspective related pointers. I'll not go very in depth like how it is being given in the ELSO manual. So what you need to write in the exam is what I'm going to concentrate on now. So I'll be covering on the introduction, the indications, contraindications, the pre-ECMO risk prediction scoring, the hemodynamic aspects, that's the physiological aspects related to this, the technique, initial management and monitoring, complications, and the algorithm for decision making on ECMO. So coming to introduction, ECMO is the form of extracorporeal life support, that allows for temporary support in cardiac and respiratory failure. So it is a modality that can be used in both cardiac and respiratory failure. That is an added advantage over tandem heart and impella. So before we go into proper ECMO discussion, we need to know about the stages in cardiogenic shock. So you have the SCA classification, that is the A, B, C, D, and E. So A is at risk, B is beginning, C is classic, D is deteriorating, and E is extremist. So E is the point where most of the time ECMO is initiated. So the concepts related to cardiogenic shock and its management, Darshan will be discussing it in detail tomorrow. So I'm not going in depth, but I just want you to know that there is a classification of cardiogenic shock, that is the SCAA classification, and what are the each aspects of the various alphabets, that is A, B, C, D, and E. So coming to the indications, the commonest indications for ECMO are patient with acute myocardial infarction with cardiogenic shock, acute fulminant myocarditis causing cardiogenic shock, septic shock associated myocardial depression, extracorporeal cardiopulmonary resuscitation, that's ECPR, cardiogenic shock post cardiotomy or post heart transplant graft failure, bridge to implantation of valves, and bridge to heart transplantation. So I think it's very easy to remember this. So at least if there are totally about 8 of it, at least it would be good to have 4 to 5 indications in mind. And the emerging indications are in massive pulmonary embolism, trauma, postpartum cardiomyopathies, drug intoxications like calcium channel blocker overdose or beta blocker overdose, and in arrhythmia storms like electrical storm. So contraindications as per ELSO, in absolute, they don't have any contraindications per se. That is, if at all the need for ECMO is there, you can proceed for it. But there are many relative contraindications, whereby if these issues are there, the success of a patient undergoing ECMO and coming out of it is going to be very less likely. So the relative contraindications are uncontrolled active hemorrhage, incurable cancers, post solid organ transplant or immunosuppression because of the risk of infections, irreversible CNS dysfunction because we are not going to have a proper endpoint, terminal heart failure who are not candidates for transplant. In those patients, putting an ECMO is not going to serve any purpose. As patients with severe aortic regurgitation or aortic dissection, because it will interfere with your ECMO cannula, the circuitry, the physiology, and patients with liver cirrhosis like child B and child C, whereby there is going to be coagulopathy invariably, and that is going to increase the risk of bleeding. So pre-ECMO risk prediction is mainly to assess the VA ECMO patient outcomes, like how you have Apache 2 score. Similar to that, we have pre-ECMO risk prediction scores. So the most common score is the SAVE score, that is the survival after VA ECMO score. But the only thing they say is it does not apply for post-cardiotomy patients. There are other prediction scores like the Encourage score, the CART shock score, and the Remember score. So if at all there are many things to read, at least the SAVE score has to be kept in mind. So the SAVE score has around 8 parameters. One is the etiology, the age, the weight, the acute pre-ECMO organ failures, the number of organ failures that were there, the duration of intubation to initiation of ECMO, the pre-ECMO cardiac arrest status, if it was there or not, serum bicarbonate pre-ECMO if it was less than 15, and the respiratory mechanics and the BP, that is the peak inspiratory pressure less than 20, diastolic BP pre-ECMO more than 40, and pulse pressure pre-ECMO less than or equal to 20. So based on these parameters, the scoring is developed, and that score will predict the likelihood of mortality. So this is the schematic representation of the ECMO circuit. I think most of you are aware of it. You would have seen this very frequently. There is always a drainage cannula and a return cannula. So the drainage cannula passes through an ECMO pump, which acts like the heart. So through that, it flows through the circuit, and also it goes into the artificial lung where oxygenation and ventilation occurs on an extracorporeal basis. And once the blood is oxygenated and the carbon dioxide is removed, again it returns back to the patient. So coming to the hemodynamic aspects, now VECMO is, as you all know, it's used in the management of cardiogenic shock. Now it is now one of the most commonly used mechanical circulatory devices for management of cardiogenic shock. So why is it being so much used? Is due to its ability to reduce myocardial work, plus provide complete hemodynamic and respiratory support. Because these myocardial work increases markedly in patients with cardiogenic shock due to maladaptive neurohumoral and vascular responses. So this flow chart is the pathophysiology of cardiogenic shock, and this needs to be memorized very well, because either whether it is cardiogenic shock or ECMO management, the physiological basis for the initiation of ECMO is based on this. So just to revise this pathophysiology of cardiogenic shock, I just wanted to put this. So whenever there's a myocardial injury, there is extensive inflammation, there is free radical production. So ultimately, there will be vasodilatation and decrease in SVR. That is because of increased nitric acid production. So because of that, the SVR comes down on one side. Whereas on the other side, because of myocardial injury, there will eventually be myocardial dysfunction because of loss of myocardial tissue. So there can be two issues that can occur. One is systolic, and other one is diastolic. So because of the systolic dysfunction, there is going to be a decrease in cardiac output. That
Very
itself
sorry
again
to
can.
interrupt.
Yes.
Shiri, your
Yes,
voice
yes.
is breaking in between. It is breaking in between. Just see your network is okay and.
Yeah, it's the network seems fine. Yeah. So is my voice audible now?
Yeah, it is audible. Just it breaks in between. That's all.
Okay. So coming to the systolic dysfunction, usually there will be a decrease in cardiac output. Then that itself is going to cause a hypoperfusion state and hypotension. That hypotension is going to cause a reduction in your coronary perfusion, and that is going to cause a further ischemia. It's like almost like a cycle. And on the other side, there is going to be a diastolic dysfunction that can occur, which is going to cause an increase in your left ventricular end diastolic pressure. Because of that, there will be backflow of blood back into the pulmonary circuit, causing pulmonary congestion and hypoxia. So that hypoxia is again going to cause ischemia. So because of these factors, there is going to be progressive myocardial dysfunction, and if it is not corrected, it's going to lead on to death. So this is very important, and it needs to be kept in mind. Darshan will be again talking about this tomorrow. So this is that time it will be more of a revision also. So in a typical VA ECMO setup in cardiogenic shock, venous blood drains blood directly from the IVC or the right atrium. So the benefit is it significantly decreases the RV preload, thereby decreasing the transpulmonary blood flow, reducing the left ventricular end diastolic volume, ultimately reducing the LV end diastolic pressures. Whereas on the other side, following the initiation of ECMO, the MAP increases by providing high volume of oxygenated blood, plus this blood that is displaced from the right atrium decreases the CVP. So because of this, there is an arteriovenous gradient that forms, and that improves the systemic circulation, especially to the kidneys and liver. And in many centers, they also add a CRRT circuit in addition to the ECMO circuit. So the advantage is you can have a gradual removal of fluid also, and that helps in further relieving of your systemic congestion. So this slide is very important. This is to emphasize the major factors that determine oxygen uptake via the oxygenator. So when from the return cannula, from the drainage cannula, when it enters through the pump and next into the oxygenation, that is the artificial lung, there are a few factors which determine the how much oxygenation is going to occur. So that is based on the extracorporeal blood flow, the hemoglobin concentration, the diffusion of oxygen through the small fibers within the circuitry, and the oxygen saturation of the deoxygenated blood. So there needs to be adequate gradient that has to be there for adequate oxygenation to occur. So this slide I've kept mainly from a practical perspective, because in practical in equipments, you're going to have cannulas being kept. So this can be a potential question that will be asked. What is the difference between an inch and French? So inch is the preferred unit for circuit tubing diameter. So that is the inner tubing diameter. And French is the preferred unit for cannula diameter. So cannula diameter, that is the outer cannula diameter. So that is the main difference between the two, the inch and French. So coming to the technique, the first one is related to cannulation. So peripheral ECMO is what we commonly use nowadays because of its easy accessibility, availability of expertise around the clock. So usually VECMO is done via femoral approach most of the time. And invariably they ask to say you put an arterial and a venous in separate limbs to avoid vascular complications. So usually they do it under ultrasound guidance or via fluoroscopy. This is the percutaneous technique. Whereas the other technique is through a cut down, which is done by cardiothoracic surgeons. That is almost like a surgical procedure. And that can also be done at the bedside itself. Other than femoral, what are the sites that can be used? Axillary or subclavian vein. But these can be to be used only if there is severe peripheral vascular disease. And once insertion is done after administration of IV heparin, that is around 50 to 100 units per kg. The main reason is you don't want the circuit to get clotted at any point, because if you have done a successful cannulation, that itself is like 50% winning the war. And there is also central cannulation, which is indicated in severe peripheral vascular disease and in patients who have come post cardiopulmonary bypass with the failure to wean. So in cardiopulmonary bypass cannulas, usually the ascending aorta is used for perfusion and the right atria is used for drainage. The advantage is high flows are possible and better drainage is possible. But the disadvantages are if infections occur, it's going to be very fatal. There is a very high risk of cerebral emboli and there is going to be increased bleeding risk. And if at all the cannulas need to be removed, the patient needs to be again shifted to the operation theater and it has to be done. So this is also another important point to be noted. The cannula size for VECMO, usually for venous, that is the drainage cannula, it is between 19 to 25 French. Whereas for arterial, that is the return cannula, it is between 15 to 23 French. So this is another important concept. That's the use of the distal perfusion cannula. So whenever femoral cannulation is used, it is very much recommended. And it should be placed under USG guidance into the superficial femoral artery using a 6 to 8 French cannula. So there will be a side arm. I have a photo of this in the subsequent slide, but just to show you the concepts of it, you need to put it under ultrasound guidance into the superficial femoral artery. The side arm of the cannula sheath is connected to the side port of the arterial cannula. And it should be accomplished at the time of ECMO institution to prevent any delays in limb perfusion. So it is highly recommended if arterial cannulas of more than 19 French size is used for access. So here you can see there will be an arterial cannula and there is a distal perfusion cannula that has been placed that is connected to the side port. And here you can see it is being inserted into the superficial femoral artery. And usually they assess the peripheries clinically or by use of Doppler. So that also has to be done on a regular basis. I will come into that in the subsequent slides. So we spoke about cannulation, distal perfusion. So once your ECMO has been initiated, the problem with use of VECMO is because of there is going to be increase of blood flow into the via arterial circuit, that's the return cannula, there is going to be increase in the afterload. So the problem is when there is an increase in your afterload, that is going to be a problem for your LV function because the LV is already in a poor ejection fraction state. So when the afterload is high, the pumping is already affected. This will add more stress to the pumping. So because of that, there is going to be an increase in the LV loading, and that is going to cause increase in the chamber size. And that itself can lead into increase left ventricular end diastolic pressures, causing increase in pulmonary congestion, causing hypoxia. So major disadvantage of ECMO is significant LV loading due to increased LV afterload plus poor LV ejection, leading to acute pulmonary edema, and there is also an increased risk of left-sided chamber thrombus because of the increase in the size of the left ventricle. So when do you want to put an LV venting is, when do you want to proceed with LV venting is when there is a pulse pressure is less than 5 to 10 millimeters of mercury, there is echo signs of distension, there is increased CVP or PCWP. So what are the methods to decrease LV venting? You have non-invasive and invasive. So non-invasive ones is to decrease the ECMO flows so that the amount of blood that comes back into the patient helps in reducing the afterload to a certain extent. Or you can go with concomitant use of inotropes and vasodilators and the use of PEEP and diuretics in case there is evidence of pulmonary edema. And you have invasive, but if you're going for invasive, it's more of catheter-based techniques. That's like a percutaneous techniques, like transaortic suction device. There is a concomitant application of an impella, LV venting via apex or mitral valve, use of IABP concomitantly, or going for a central cannulation or a atrial septostomy. So atrial septostomy is the most invasive, whereas the transaortic suction device is like a fluoroscopic guided device. But the problem is all these cannot be done at the bedside. They need to be taken to the cath lab or to the operation theater. So it's a cumbersome procedure that needs to be looked into. So coming to the initial management, we need to have goals. So like how we routinely see a critical care patient, you go with a systematic approach. You go CNS, CVS, RS, GA, and hepatic, renal, and hematological. So if you cover every aspect in relation to patient and in relation to ECMO management, you wouldn't miss anything that is likely to create complications. So that is one thing that you always need to keep in mind. So first, coming to the respiratory management, once you start the patient on ECMO, you can come down on the ventilatory support. So they say the ventilator goals is to get the FiO2 down to 0.7, a peak inspiratory pressure less than 35, plateau less than, peak inspiratory less than 35, plateau less than 25, PEEP less than 15, and respiratory rate less than 10. So it's so as to give the lung sufficient time for recovery. And the ECMO flow rates are kept between 2.1 to 2.4 liters per minute per meter square. This is based on the cardiac index. And the important thing to note is don't go less than 2 liters because the lesser the flow, the more the risk of stagnation, and that is going to increase the risk of thrombosis of the circuit. Then next, coming to the line pressures, the pre-membrane pressure has to be less than 300 and the transmembrane pressure, that is the difference between the pre and the post-membrane pressure, should be less than 50. This is at the level of the artificial lung. So if it is more than 150 millimeters of mercury, that's the pressure difference that is going to be there, then it's a high indication that you need to change the oxygenator. Just to show you where we check the pre and post membrane pressures, I'll just show you that. 1 second. So here you can see that P2 and P3 is there. This is the pre-membrane and the post-membrane. So the difference between those two will give you the pre-membrane or the transmembrane pressure. So normally it is less than 50, but if it goes more than 150, then it's a high indication that the oxygenator is non-functioning. So it needs to be changed. So then next is about the temperature management. They say to go with normothermia. That is the ELSO guidelines recommendation. But in 2022, there was a study called the Hypo-ECMO study. That is, they studied whether PTM can be used in ECMO patients. Even though they showed that it's associated with reduced hemorrhagic complications, there was no improvement in any mortality. So though it tries to reduce one morbidity factor, it didn't have any change in the mortality. So that is one important thing to be noted. The next is about the anticoagulation. Most of it is based on institution protocols because each institute will have a certain style of monitoring. But in most scenarios, in the first 24 hours, you go based on the activated clotting time. Usually the target is between 140 to 160 seconds. And beyond 24 hours, you go based on the APT2. You target between 45 to 55. In some places, they go between 50 to 70. So that is again at the discretion of the institution. But from an exam perspective, I think this would be fine. And you need to follow up investigations on a regular basis. So you need to do daily complete blood counts, mainly because once you have the circuit in situ, there is going to be a risk of bleed, there is going to be risk of hemolysis, and there can be risk of thrombocytopenia because of the circuit causing activation of platelets or because of heparin-induced thrombocytopenia. So that needs to be looked into. Then blood urea and serum creatinine also needs to be checked along with electrolytes because there may be already a pre-existing AK that could have occurred because of ischemic ATM. But once the ECMO is initiated, we need to assess the trend of AKA and also monitor the renal parameters because if at all there is any worsening, we'll have to consider the need for a CRRT simultaneously. And the LFT also needs to be assessed to ascertain the severity of the ischemic hepatitis that occurs simultaneously. So daily chest X-rays need to be done and plasma-free hemoglobin when indicated. That is when hemolysis features are there. With the daily D-dimers and blood cultures, they say thrice a week is obtained from the circuit, like surveillance cultures. So hematological goals are there are 4 things you need to keep in mind: hemoglobin, platelets, INR, and fibrinogen. So these goals are those that you already know about. I've just kept it in a more systematic format so that it is easy to write it in the exams. So platelets, if it is more than 50,000 in a bleeding patient, you need to transfuse. And if it is more than 20, that is, if it is between 20 to 50,000 or less than 50,000 in a non-bleeding patient, then you will have to consider transfusion. Similarly, if the INR is less than 1.5, that's going to be our goal in a bleeding patient, whereas if it is less than 3, that needs to be the goal in a non-bleeding patient. So you need to keep it in mind. And the fibrinogen, if it is a bleeding patient, you need to keep it more than 1.5 grams per liter. Whereas if it is a non-bleeding patient, you can keep it at more than 1 gram per liter. And the hemoglobin target needs to be kept between 7 to 9 grams per deciliter, but it needs to be kept in mind. It is not about the numbers, it is about the trend. Because some patients may have an initial hemoglobin of 12 and then suddenly it would have come down to 10. So you need to assess the cause and then simultaneously assess the scenario of the patient and decide on product transfusions. So this is, if at all there is no active bleeding that is that, but the HP trend is gradually coming down, then this should be considered the target. And if the patient has an acute MI, then you need to go with the target more than 8 rather than 7. So next is about the complications. So the general complications that can be there because of ECMOs, line sepsis or VAP, that is like ICU-acquired infections can be there. Then there can be pump failure or circuit malfunction. Because the patient is on multiple cannulas, lines, and the patient is invariably sedated and paralyzed, there is going to be a high risk of post-intensive care syndrome. So that needs to be kept in mind. And there can be air in the circuit, and that can be catastrophic. Then there can be circuit thrombosis because of inadequate flows. Like I told, if it's less than 2 liters, then it's something to be worried about. Or there is inadequate anticoagulation, whereas one that can be because of inadequate heparinization, or there can be heparin resistance, whereby there is more than requirement of 35,000 units in 24 hours. So in that kind of scenario, because of antithrombin deficiency, then you need to transfuse FFPs to replenish the antithrombin levels and then continue with your heparinization if it is feasible, or go for alternative anticoagulation. Then in circuit thrombosis, can also be because of HIT. The HIT is a separate topic by itself. We'll discuss it later. Then anticoagulation related complications again can be there, like bleeding or heparin-induced thrombocytopenia. Cannulation related issues can be there, like vessel perforation, arterial dissection, distal ischemia, malposition, or DVT. So that's also very important to be kept in mind. And Ecmo specific complications is differential oxygenation, that is the North-South syndrome or Harlequin syndrome, and sequelae of LV overloading, that is pulmonary edema, hemorrhage, or cardiac thrombosis. So, general circuit thrombosis, anticoagulation, cannulation related, and VS Ecmo specific. In this, the most important thing that you need to keep in mind and you need to have it in your mind before the exam is the North-South syndrome. So before we go on to that, I'll just give you a cover of the Ecmo circuit malfunction. What are the possible problems that can occur? One is there can be console or power failure. That is, our bad luck, suddenly the ICU power supply can get cut. That can cause a total abrupt power cutoff to the Ecmo circuitry. So usually there will be a rotator that will be attached to the Ecmo circuit that can be used. Or if there is any air in the circuit, that also needs to be looked into and it needs to be troubleshooted at the earliest. There can be membrane lung dysfunction that causing an impairment in membrane lung gas transfer efficiency. Circuit disruption can be there, especially if there are a lot of circuitry that is being placed on the floor and the staffs or doctors or paramedics or housekeeping don't adequately look into the issue. They may accidentally pull the circuitry and that can cause disruption. Then there can be gas supply interruption, which can also be there because of the disruption, because of some excessive movement around the patient causing disconnection of the tubes. And inadvertent decannulation, almost similar to the same mechanism. So coming to the North-South syndrome, that's differential hypoxemia. So it occurs when oxygenated blood from the Ecmo circuit mixes with the deoxygenated blood from the native heart. So that results in a differential hypoxia, that is higher PaO2 in the lower limbs and lower PaO2 in the upper limbs. So the important thing is this usually occurs in femoral VA Ecmo circuitry. So this situation occurs when the native LV function improves and competes with upcoming stream from the femoral circulation. I'm repeating it. So the situation occurs when native LV function improves and competes with upcoming stream from the femoral circulation. The battleground line drawn somewhere in and around the aortic arch. So this is where usually the differentiation occurs. So the treatment is relatively urgent and needs to go from the least to the most invasive. So I think this one line can be applied to most of the diseases that occur in critical care, that is in your management. So they go with the least invasive to the most invasive, that is pharmacological to any other invasive therapy. So if the lungs are at all functional, we can optimize our oxygenation and increase your O2 delivery as well as treat lung pathologies. That is number one. That is, you optimize the ventilation on the via adjusting the ventilator settings. Or you can increase the pump flow to increase the drainage into the Ecmo circuit and decrease the amount pumping through the heart. Or you can add another circuit that branches from the aortic cannula to the return oxygenated blood to the right heart to be ejected forward. That is a VV Ecmo circuit. So one is you can adjust the ventilator settings, or you can increase the pump flow, or you can add another circuit. That's the easiest way of remembering it. So we spoke about the indications, contraindications, then the technique, in technique cannulation, the distal perfusion cannula, then about the LV venting, then we mentioned about the initial management, that is the system wise, what are our goals that needs to be done, what are the investigations that needs to be done, the complications that we look into, VA Ecmo specific complications related to LV venting and this differential hypoxia. So we have covered this much. The next thing is about the monitoring. So coming to monitoring, we need to monitor the ECG rhythm and map. We always need to monitor for dysarrhythmias such as VF that may prevent ventricular ejection. Oxygen delivery. So if there is decreased O2 delivery in the because of decreased Ecmo flows, decreased hemoglobin, or decreased O2 saturation, that needs to be troubleshooted. Or if there is increased O2 consumption because of fever, shivering, because as I said, the adequacy of the oxygenator providing adequate oxygenation depends on various factors. So one among that is about the O2 delivery. So if any of these two issues are there, that needs to be troubleshooted. Otherwise, the O2 delivery back to the patient may be hampered. So then we need to look into the gas exchange, that's the PO2 and PCO2, and it is important to look for Harlequin syndrome. So usually they say you have to keep a pulse oximetry in the upper limbs, so to monitor the saturation. So any variation that is there or the perfusion issues are there, that may help to identify any issues related to the oxygenation in the upper limbs. Then you need to assess for pulsatility. So lack of pulsatility on arterial waveform can either denote poor myocardial function, excessive Ecmo support, inadequate preload, or RV failure. So these are usually the 4 reasons of low pulsatility on an arterial waveform. Then you need to monitor the intake and output charting and flows. The important thing is usually low flow alarm is a frequent issue that can occur, and you need to assess why it is present. So usually causes is due to decreased preload, excessive afterload, that is presence of kinking or any thrombus, or inadequate revolutions per minute. So it's the Ecmo settings based issues. And you always need to assess the distal limb of pulses for cyanosis. And also, if at all there is a decreased pulse on a clinical exam, then you need to do a Doppler assessment. Plus, you need to assess the limb for any discoloration. So if any of those signs are there, then you need to troubleshoot it at the earliest to prevent further limb gangrene or any other complications associated with it. And neuromonitoring in the form of GCS, pupils, or non-invasive ICP monitoring like ONST or transcranial Doppler can also be done. So this is just a summary of what I had told. So since in the previous one, I had made it like small animations, this will help you in writing. If at all the question is asked related to monitoring and Ecmo, I think this diagram will give you an overview so that it will be easy to answer. It's almost similar, almost everything that I covered in the previous slide. So I'm going to the next one. So you don't have to read much about this. This is just to show you that if at all there is pump flow rate abnormalities, there are various ways of troubleshooting it. So you don't have to read about this for now. This is not important from exam perspective, just to make you aware that there are various ways to approach to pump flow rate abnormalities. So once the patient has improved on VA-ECMO with progressive resolution of the underlying disease process, weaning can be initiated. It's almost similar to a patient on mechanical ventilation. So once your patient has the underlying disease process has resolved, then you can consider weaning. So the preconditions for weaning are: one, the cardiac pathology should be consistent with weaning. That is, they should be in a improving state. There should be an appropriate time frame for recovery from the etiology. So it depends on the etiology for cardiogenic shock or cardiac arrest. So it's usually shorter in patients with drug toxicity or ECPR, and it may be longer in patients with an acute MI with myocardial stunning. And patients should have stable hemodynamics on low or no or low dose vasopressors. With the stable rhythm, good and consistent pulsatility and arterial line tracing, MAP more than 60, appropriate LV venting in case of LV distension. And there should be stable recovering organ dysfunction. That is, lung function should be good. That's an FiO2 less than 0.6 should be the target with safe lung ventilation. And the chest X-ray should be clear or almost clear. Liver and lung function should have normalized. Lactate should have come to be normal levels, and the fluid balance should be optimal. They say ideally you need to get the patient into a negative balance. And a multidisciplinary team consensus should be made on the prognosis. That is, the attenders should always be updated about the status. So there can be further complications that can occur even after decannulation. So that should be always be informed to the patient attenders. And during this whole process of ECMO, communication is a very, very important aspect that needs to be dealt with. So the algorithm for decision making on VA ECMO is: patient had a cardiogenic shock, you put the patient on ECMO, you evaluate for end organ function, that is brain, lung, renal, hepatic, and gastrointestinal. So if the arterial pulse pressure is more than 10 and pulmonary edema is negative, be in vasoactive medications, you evaluate the ventricular function using echo and follow the end organ recovery, that is creatinine, LFT, and lactate levels. Whereas if the pulse pressure is less than 10 and pulmonary edema is present, then you need to go for LV decompression. So once on either side, once you have done both, you assess if the vasopressor requirement is low, the ejection fraction is more than 30, and MAP is more than 60 with ECMO flow rates of 1 to 2 liters per minute for 1 hour. That is if you are in the weaning process. So if all of these are satisfied, then you go ahead with the weaning trial. First, you ensure there is a therapeutic APTT levels, because like I said, when you keep them at low flow rates, there is going to be a risk of circuit thrombosis. So then you clamp the ECMO circuit for 3 to 5 minutes. Once you clamp the circuit, you assess for 4 parameters: the MAP, the cardiac index, the LVOT VTA, and the CVP. So MAP should be more than 60, cardiac index should be more than 2.2, LVOT VTA must be more than 15 centimeters per second or 0.15 meters per second, and CVP should be less than 18. So if it is successful, you go with the decannulation. But if the patient requires high vasopressors and inotropes, the ejection fraction is low, MAP is low, then you have to consider a temporary VAD. So if the patient is on 2 end organ dysfunction, then you need to go more with palliation, because the outcome is not going to be very favorable. But if there is just 2 or less than 2 end organ dysfunctions, then you can consider a durable ventricular assist device. Or if the weaning trial has failed, but the patient is on low supports, then in that scenario also you can consider a durable VAD. So once a durable VAD has been placed, you can go into 2 fates. One is a destination therapy or heart transplantation. And now destination therapy is continuation of further care with the durable VAD. So once you come to the weaning and it has been successful, the next is about decannulation. So how do you go about decannulation is, you assess whether it is a surgical cannulation or not. So if it is a surgical cannulation, then you can go ahead with surgical decannulation. The advantage is there will be direct closure, there will be direct control of bleeding, and embolectomy can be done if at all to prevent distal limb ischemia. But you need to do this only in an operation theater, and there is a risk of local wound issues and scar formation. Whereas if it is not a surgical cannulation, usually either surgical decannulation can be done or cannula removal and application of local pressure can be done. This can be done at the bedside itself and can be done by bedside clinicians itself. But the issue is there is a high risk of vascular complications like pseudoaneurysms. The last one is, if at all there is percutaneous cannulation that was done, then percutaneous decannulation can be done using closer devices. The advantage is no surgical scar is there, can be performed at the bedside, and avoid complications associated with surgical wound infections. But it has not been well validated, and it has been done only mainly for femoral decannulation. So coming to the summary of weaning, the prerequisite is ensure adequate time for resolution of pathology and ensure adequate time for organ function stabilization. Ensure safe lung ventilation and oxygenation. Make sure the FiO2 is less than 0.6. Check the ABG for adequate oxygenation and ventilation. Ensure adequate anticoagulation prior to decannulation. Like I said, if at all the patient goes into failed weaning, you need to again restart them on ECMO. If at all the circuit thrombosis has developed, it makes things worse. And stepwise reduction of VA ECMO blood flows. You need to come down from 2 then reduce it by 0.5 liters per minute with monitoring of hemodynamics and vasoactive supports, and ensure stable hemodynamics on low flow vasoactive supports for at least 24 hours with a flow of 2 liters per minute prior to the next step. That is the minimal flow that needs to be kept. Now, here I've mentioned in relation to cardiac output, but the previous ones were in relation to the cardiac index. So both are almost acceptable. And the final echocardiographic guided stepwise reduction should be every 15 minutes to the minimal accepted blood flow. Like I said, you need to look at the LVOT and the echo, that is the ejection fraction. And leave the minimum acceptable flow only less than 15 minutes to prevent circuit thrombosis. So that is also very important. So MAP should be more than or equal to 60 and CVP should be less than 15 or preferably less than 18. And acceptable echocardiographic parameters, you have LV and RV. LV, no significant LV dilatation. There is no LV venting. EF should be more than 25% and LVOT must be a minimum of more than 10 centimeters. Ideally, it should be more than 50 centimeters per second. And for RV, the TAPC should be more than 10 mm. There should not be any worsening regurgitation of the tricuspid valve. There should not be any increment on RVOT VPA or recurrent of RV systolic function to normal or mild dysfunction. That is from a previous moderate to severe dysfunction to normal to mild RV dysfunction. So this is the best way of remembering it because there are more parameters that are mentioned, but from an exam standpoint, these would be easier to remember. So I've just concentrated on these parameters. So, okay, thank you. So this is about VA ECMO. So next we will go into cardiac pacing. Okay, is the screen visible? If the screen is visible, I'll proceed because I've not got any affirmation on that.
Screen is visible, Srihari. Just put on the press. Yes. Okay.
Okay, so the next about topic for discussion is about cardiac pacing. So I'll be concentrating on temporary pacing and permanent pacemakers. Now, the important thing is, from a theory perspective, there have not been much questions asked in relation to this, but from a practical standpoint, it's very important because invariably pacing equipments will be kept equipments. There can be radiology related questions that can be asked, and there can be ECGs related to cardiac pacing that can be asked. So it is important to know about it. So I will cover both of them from an exam perspective for better understanding. So first, coming to temporary pacing. So these will be the topics I'll be discussing. One is about the introduction, the pacing techniques, indications, contraindications, preferred vascular access, procedure, pacemaker programming, and complications. So coming to introduction, temporary venous cardiac pacing involves electrical cardiac stimulation to treat symptomatic bradyarrhythmia until it resolves or until long-term therapy can be initiated. The purpose of temporary pacing is to re-establish normal hemodynamics that are acutely compromised by a slow rate. So as Bhuvaneshwari had told, cardiac output is basically your heart rate into stroke volume. So if your heart rate is going to be low and that can compromise the cardiac output, so that itself can cause various complications. So that needs to be addressed in the appropriate setting. So regarding pacing techniques, there are various techniques that can be done. It can be done internally using transvenous endocardial leads, which is what we normally do. That's the transvenous pacing. Or they can be done externally via transthoracic patches. That's the transcutaneous pacing. Or internally via atrial or ventricular epicardial leads placed at the time of surgery, most commonly CABGs. Or any valve surgery, or it can be placed internally via an esophageal electrode, which is primarily used for atrial pacing and recording. This is just from a theoretical perspective, but it's not very commonly used. So coming to the indications, most common indications are related to electrolyte disturbances like hyperkalemia or hypercalcemia. Drug toxicity, drug toxicities like again beta blocker toxicity or calcium channel blocker toxicities, or post-procedural. That can be injury to the SA node, AV node, or His bundle fibers. That can be because of post-cardiac surgery, post-heart transplantation, or a trans-aortic valve implantation. Infections like Lyme disease, Chagas disease, or subacute infective endocarditis causing damage to the His Purkinje fibers. The good thing is both Lyme disease and Chagas disease is very rare in India. So that is one reassuring thing. Then acute MI and use during permanent pacemaker revisions. That is either due to PPA infections or lead failure. The important thing that needs to be kept in mind is the transvenous pacing needs to be kept for the lowest time possible. Now, there are certain references that say that you need to keep it for maximum of 7 days or no. Whereas some say you can go to a maximum of 14 days. So ideally, it should be kept for the best time period will be kept for 1 week. But if at all it is being done in a very sterile environment, the risk of infections in the ICU is low, then you can probably extend it to a maximum of 2 weeks, not more than that. So contraindications, there are no absolute contraindications, like similar to VA Ecmo, but relative, if at all the patient has a prosthetic tricuspid valve, there is a possible risk of damage, and if the patient has received thrombolysis, then it would preferably not be given because the risk of bleeding is high. So coming to the procedure, so the preferred vascular access is to go with the right IJV or the left subclavian. So the rationale for that is the curvature of the pacing lead goes very freely if either of these axes is used. The ease of advancing the lead in the heart and the underlying venous anatomy. So when you do a transvenous lead as placement, only the ventricular lead is inserted. So it's almost the same thing that is done for a central venous catheterization. The only thing is after you put a dilator, rather than putting the central venous catheter, that can be single lumen or triple lumen, you put a sheath. So once you put the sheath in place, there is a transvenous lead that is usually inserted. And usually the newer generation leads have a balloon tip catheter to prevent any kind of trauma to the endocardium. So that can be advanced based on the markings indicated the distance from the tip, or it can be confirmed via Ecmo or fluoroscopy. So these are the ways of ascertaining the position, and continuous ECG monitoring is recommended in all patients because as you would have seen when you pass a central line guide wire, as it hits the endocardium, there is a high chance arrhythmias can be triggered. It can be most commonly we encounter VPCs, but worst case scenarios, you can have non-sustained VTs also. So that indicates that the lead has come in contact with the RV. So that needs to be kept in mind. So once that has been done, the lead is then connected to a pulse generator. So coming to pacemaker programming, this is very important. And invariably in practicals, if you get a cardiac case, they will be asking questions related to this. If at all your case discussion goes towards bradyarrhythmias, they will ask you about pacemaker insertion and pacemaker programming. So I would request you to concentrate on this slide. So the important thing is once you put on transvenous pacing, the important mode is to go with the VOO mode. That is the ventricular pacing alone is there. The O and O is sensing is kept at 0. There is no output. And the other O is the response to any rhythm changes. That is also kept at 0. So it is a asynchronous pacing mode. And the settings, initially heart rate is kept at 60 to 70 beats per minute. Then the pacemaker sensitivity, it is initially kept at maximum. That is kept at maximum of 20 millivolts, but though it can be set between 0.8 to 20 millivolts. Now, the important thing is, what is pacemaker sensitivity? So it is the minimum current at which the pacemaker is able to sense intrinsic rhythms. All right. So I'm repeating it again. It is the minimum current at which the pacemaker is able to sense intrinsic rhythms, and it is expressed in millivolts. So important thing to note is, the lower the number, the more sensitive the pacemaker is. So it is hitting the tip adequately, and it is able to sense the intrinsic rhythms. So the next thing is about the pacing threshold. So we saw the sensitivity should be kept at the maximum and then reduced. So it can be kept ideally between 0.8 to 20. The pacing threshold should be less than or equal to 1 milliampere. So what is pacing threshold? It is the minimum pacing output required for pacemaker capture. That is, capture is to produce a action potential that leads to myocardial contraction. So pacing threshold is the minimum pacing output required for pacemaker capture. That is, capture is the minimum pacing output at which an action potential is generated, leading to myocardial contraction. So the next thing is about the pacing output that should be kept to 2 to 3 times the pacing threshold. So pacing output is the current with which it produces a brief pulse. That is, the pacemaker current is being produced. So that leads to depolarization of the myocardium. So 3 definitions that needs to be kept in mind is the sensitivity, the pacing threshold, and the pacing output. So complications, it is important to monitor for these while transvenous pacing is done, or transvenous pacing is in situ. There's a small spelling error, please note it. So the various complications are lead dislodgement and disconnection can be there. There can be bleeding, myocardial perforation, leading to cardiac tamponade. Though nowadays it is very rare because nowadays balloon tip catheters are used, so the injury rates are very low. Or there can be catheter insertion related complications like pneumothorax. Risk of infections are there, especially if it is kept more than 1 week. Catheter knotting can be there, and air embolism can be there. So these are the potential complications that needs to be kept in mind. And post procedure, whenever the patient is being examined, you always need to assess on a regular basis for pericardial friction on auscultation. That can be indicative of cardiac perforation. Hypotension with muffled sounds and elevated jugular venous pressure, suggestive of a cardiac tamponade, or asymmetrical or absent breath sounds, suggestive of a pneumothorax. Even though these are clinical, it would be always better to go with lung ultrasound and cardiac ultrasound assessment also. So with regard to use of temporary pacing, there is a 2021 guidelines for that. So they have indicated pacing in symptomatic patients with bradycardia or tachycardia form of sinus node dysfunction to correct bradyarrhythmias and enable pharmacological treatment unless ablation of tachyarrhythmias is preferred. That is a 1B recommendation. And pacing is indicated in patients with atrial arrhythmias and permanent or paroxysmal 3rd degree or high degree AV block, irrespective of the symptoms. That is a 1C. So in these 2 scenarios, it is ESC guidelines to go ahead with the transvenous pacing initially, and based on the scenario, you can decide on a permanent pacemaker insertion, which I'll discuss subsequently. So coming to permanent pacemakers, I will be discussing about general considerations, indications, contraindications, paths, pacing nomenclature, pacing rhythms and abnormalities, and complications. So the general consideration is most management decisions regarding permanent pacemaker insertion are driven by the following factors. So one is about the association of symptoms with bradyarrhythmias. So dizziness, lightheadedness, syncope, fatigue. That is like in your AHA algorithms, you have this CHAPS, that is chest pain, heart failure features, altered segmentation, poor peripheral perfusion, low BP. All these features also can be looked into. Then the location of the conduction abnormalities, whether it is infra-His AV blocks or 2nd degree Mobitz 2 or 3rd degree blocks. In these kind of cases, TPA is shown to improve outcomes, and the most important thing is there should be absence of a reversible cause. So that needs to be kept in mind. Because if there is going to be reversible cause, usually correcting that itself will actually improve your bradyarrhythmias. Like example, electrolyte abnormalities. So indications, we have class 1 and class 2. So this is one of the easiest way of putting it down so that it's easy to go through it during the revision time. So the class 1 is presence of symptomatic bradycardia. That is in your AHA, you have CHAPS. That is like any kind of chest discomfort, heart failure, altered mentation, poor peripheral perfusion, or systemic hypotension. Those scenarios, in the presence of bradyarrhythmias, it becomes an indication to go ahead with the BPA if at all it is persistent with absence of reversible causes, or presence of a symptomatic sinus bradycardia due to long-term drug therapy of a type and dose for which there is no accepted alternative, complete heart block irrespective of the symptoms, and a symptomatic second-degree heart block. So in these scenarios, permanent pacemaker insertion is indicated. Whereas class 2 indications are sinus node dysfunction with unexplained syncope, asymptomatic second-degree Morbitz 2 block, trifascicular or bifascicular block with syncope, or post-anterior wall MI. Whereas contraindications are there is excessive risk of bleeding due to vascular access. The patient has an ongoing bacteremia, whereby there can be seeding of the bacteria onto the leads, thereby causing lead infections, and that can further increase the risk of infective endocarditis, which Bhuvneshwari had spoken previously about. There is a risk of intracardiac thrombus and in patients with prosthetic tricuspid valve, it is not indicated to be placed because of the risk of injury or rupture of the valves itself, or further any endocardial complications. So parts include battery, circuit, leads, and electrode. So the battery is the power source that generates the impulse. The circuit controls the pacemaker operations. The leads are insulated wires that deliver electrical impulses from the pulse generator to the heart. And the electrode is the conductor at the end of the leads that delivers the impulse to the heart. So I'll just revise it. Parts are battery, circuit, leads, and the electrode. So here you can see, here you have the battery, then the circuit, then you have the leads and the electrode tip. So you have the pacing nomenclature. So the easiest way to remember it is PSR, PT. Sorry, PSR, RT. So the first one is in relation to the chamber that is paced, where O indicates none, A indicates atrium, V indicates ventricle, and D indicates dual. The second one is the sensing, and the third is the response to sensing, where it can be either triggered or inhibited or dual. Then fourth is rate modulation. That is, it uses a physiological sensor rather than a sinus node to adjust pacing rate according to the physiological needs of the patient. That is, if patient is in like in an exercise mode, or there is any kind of an underlying insult or event like infections that is there, the pacemaker tries to adjust the according to the patient's physiology. And multi-site pacing, though it is not commonly used, it is also one of the things that can be kept. And usually it can be kept as anti-tachycardia or resynchronization. That is more commonly placed for implantable cardioverter defibrillators. So one important thing I wanted to discuss is about overdrive pacing and anti-tachycardia pacing, because if at all a question is asked related to electrical storm, this concept can be added to that. So how it helps? So it actually creates a re-entrant pathway that bypasses the AV node or an ectopic unregulated pacemaker. So it by disrupting the re-entrant circuit or overriding the ectopic pacemaker, it changes the pattern of depolarization and creates a more uniform repolarization. The main benefit of it is in patients with refractory VT, like in electrical storm. So overdrive pacing increases the rate of depolarization, thereby decreasing the ventricular refractory period, thereby reducing the susceptibility to a R on T phenomenon. So patients with an AV junction tachycardia, atrial flutter, and SVT with rapid ventricular response that fail to revert to conventional therapy, overdrive pacing can be used. And usually they say to keep an external rate of 10 to 20 beats per minute greater than the native rate. So this is an ECG that shows a normal atrial and ventricular pacing spike. This is more important from a practical exam perspective. So here you can see ventricular pace rhythms. That's the ventricular pacing spikes precede each QRS. Then you have pacing abnormalities. So one of the most commonest are failure to capture or pacing failure. So here you can see that the ventricular spikes that follow P wave, but there is no pacing thereafter. Here we can see there is no pacing that is occurring thereafter. So the usual etiologies related to failed pacing can be because of lead dislodgement or malposition, whereby the management is reposition of the leads. Inflammation at the electrode surface, which is again repositioning and increasing the output of the pulse generator. So that needs to be done by connecting it to a specialized system. It is done by a specific company. Whichever company, like if it is Medtronic, that company has to specifically come. The representative has to come and help aid in changing the settings. If at all there is battery depletion, then the battery change has to be done. But if at all battery change has to be done, temporary venous pacing has to be done initially. Keep the rhythm adequate and then rate adequate, and then proceed with the change of battery. Or if there is a change of pulse generator failure, then you need to replace the generator. Of lead maturation is there, then you have to assess the change in sensing. And if they have placed a magnet, then it is necessary to remove the magnet. So these are related to failed pacing. Now there can be rapid ventricular pacing also. So there are two common etiologies. One is pacemaker mediated tachycardias and sensor induced tachycardias. Now, in relation to both of this, they say that the initial generation of pacemakers that were used were actually had a high predisposition to cause these problems. But with the current pacemakers, the risk of complications related to this is very less. So if at all there is a pacemaker mediated tachycardia, the management is, if at all temporary management is to apply a magnet to make it into a asynchronous mode. Whereas the definitive management will be reprogramming of the pacemaker, where, like I said, there is representative has to come, there is a specialized computer or laptop for that, and to that the settings are adjusted. So this is just a ECG of a runaway pacemaker, that is paroxysms of rapid pacing spikes of 2000 beats per minute with decreasing amplitude and rate. So this fails to excite the ventricles due to the low amplitude spikes. So again, the management for this is to disinhibit the pacemaker with magnet, then urgently implant a temporary pacing device if the patient is pacemaker dependent, and the definitive management is reprogramming the pulse generator. So the complications is almost similar to that of temporary pacing. So you have lead dislodgement and disconnection, bleeding, myocardial perforation that can lead to cardiac tamponade, pneumothorax, infections, catheter knotting, air embolism, runaway pacemaker, and pacemaker mediated tachycardias. So this was the last slide, and this is an important slide which I thought I should keep, because in the DRNB exams, invariably they're asking bouncers. So this is one of the potential bouncers that can be asked, because leadless pacemakers is now slowly coming up in a big way. So it does not need any specific leads and all. Via fluoroscopy itself, via femoral route, can be implanted in the right ventricle, and that can lead to generation of impulses, thereby aiding in your rate modulation. It is increasing your heart rate. So the advantages is it minimizes the risk of infections. It avoids the complications related to surgery. There is no flap that needs to be made on the chest, and it is very small and self-contained, self-contained with the inbuilt battery. And the issues so far that had been reported in all the studies in relation to leadless pacemakers is, one, because it is a new modality, there are only certain studies that have come in relation to this, and they had said that battery malfunction was one problem, and it has been validated only for single ventricular functioning so far. So the ESC guidelines in relation to pacing had shown that leadless pacemakers should be considered as an alternative to transvenous pacemakers when no upper extremity venous access exists, or when risk of device pocket infections is particularly high, such as previous infections and patients on hemodialysis. So these should be considered for the indications for leadless pacing. And leadless pacemakers may be considered as an alternative to standard single lead ventricular pacing, taking into consideration life expectancy and using shared decision making. That is, there should be a multidisciplinary team approach in discussion with the patient attenders. So it all comes as 2A and 2B. That is, it can be considered in subset of patients. So this is related to leadless pacemakers. So then this is also completed. So the last topic is in relation to defibrillators. This is a relatively small topic. So we had added this topic because there was one question that had been asked on this in October 2023 DRNB exams. That is in relation to the types of defibrillation, the energy selection, and about the relevant trials. So I thought it is important to know about it. Again, I've only mentioned things from an exam perspective. There is so much of detailed concepts in relation to defibrillation, but within 5 pages of answering a question, it will not be feasible. So I will try to cut down as much as possible for the benefit of revision. So as you all know, electrical cardioversion and defibrillation have become routine procedures in management of patients with cardiac arrhythmias. So cardioversion is the delivery of energy that is synchronized to the QRS complex. And defibrillation is the non-synchronized delivery of a shock randomly during the cardiac cycle. So this is one thing that most of you know about it. This is for revision. So the types of defibrillation are manual, automated external defibrillation, and implanted cardioverter defibrillator. So the mechanism is defibrillation is the passage of an electric current of sufficient magnitude across the myocardium to depolarize a critical mass of cardiac muscle simultaneously. So by depolarizing all excitable tissues of the circuit and making the tissue refractory, the circuit is no longer able to propagate or sustain re-entry. So it helps to enable the natural pacemaker to resume control. So this is the main way how it helps. So successful defibrillation is defined as the absence of VF VT at 5 seconds after shock delivery, although the ultimate goal is return of spontaneous circulation. So the main factors that affect the defibrillation success are, you have device-related variables first and patient-related variables. So device-related variables are electrode placement, that is whether you keep it anterolateral or anterior-posterior. So now previously we used to do it in anterolateral, that is one is kept at the right side, that's medial to the sternum on the right side, and the other one is kept at the apex. So now recent studies have shown that anteroposterior is associated with higher resolution of atrial fibrillation to sinus than anterolateral. And it is coming up in a big way. Then the pad size, they say that larger pads, that is more than around 12 centimeter size pads versus 8 centimeter size pads, is associated with defib success. And whether you use handheld versus patch. So with improved electrode to skin contact and reduced transthoracic impedance, that helps in better outcomes with handheld use rather than adhesive patch electrodes. So the problem is with the adhesive pads, you just apply it on the chest, but we don't give any pressure. So there is the electrical current delivery may have certain amount of impedance. But when you use a handheld defibrillation, when you're giving pressure on the chest, that itself may help in reducing the impedance and providing current more effectively to the cardiac tissues. And monophasic versus biphasic, previously it was always a debate about which is more effective. As you know, monophasic defibrillators work in a fashion where the current only flows from one electrode to the other. It's a unidirectional flow. And the thing is, it requires a high amount of energy. Thereby, there is always a risk of myocardial injury. Whereas with biphasic, the current flows from one electrode to the other, and then it moves from that second electrode back to the first electrode. So there is a lesser amount of energy that is required. And the advantage is because of that, there is a lesser risk of myocardial damage. But both are almost efficacious. There were few studies that had been done. That's the Orbit study, the Timber study, and the Orca study. I have kept this in the most easiest way. In Orbit, they'd shown that biphasic is superior to monophasic, especially in patients with VT and VF. And Orca also to the same. Whereas in Timber, they said that biphasic is almost equivalent to monophasic. So the O's were in favor of biphasic, the T was in favor of either of them. So the most preferred mode is to go with biphasic, whereas if biphasic defibrillator is not available, then you can go with monophasic, but the dose of monophasic in a defibrillated state is to go with 360 joules. Then you have patient-related variables. The most important is the transthoracic impedance. That is, the higher the impedance, the less likely the success. So it is determined by factors like energy levels, the electrode to skin interface, the electrode pressure, the phase of ventilation. They say that during inspiration, there is more impedance that will occur because of the lung to the lung acts as an impedance layer between the skin and the heart. So they say that around there is an impedance of about 10 to 15% more when the patient is in the inspiratory phase. So that needs to be kept in mind. And myocardial tissue and the conductive properties. Like if at all the patient is having already scarred myocardium, then the success of defibrillation is going to be less. And the type of arrhythmias. So in non-organized rhythms, the wave fronts are multiple and involve more myocardial mass. So more energy is needed for termination. That is in VF, pulse VT or pulseless VT or atrial fibrillation. Then the duration of arrhythmia. So the longer the duration, the lesser the success. The use of antiarrhythmic drugs, they say sodium channel blockers are associated with increased energy requirements, and potassium channel blockers and catecholamine use is associated with lower requirements. There has not been any established physiological understanding for this, but based on various trials and studies, they had found out that these are the likely probabilities that can occur. And patients with an underlying implantable electronic devices, the patch should be placed in posterior position to reduce the risk of damage to the implanted devices. So the indications and the energy selection, most of you would know about it. Atrial fibrillation is 120 to 200. Flutter and PSVT is 50 to 100. Pulse VT is 50 to 100. And pulseless VT or VF is 200 with biphasic, and monophasic is 360. So the complications related to defibrillation are, there can be ST segment and T wave changes, which are usually transient with no or minimal elevations in troponin levels. It is again lower with use of biphasic defibrillator. Arrhythmias and non-conduction abnormalities. The most common are sinus tachycardia, non-sustained VT or VF, and bradyarrhythmias. But bradyarrhythmias are very rare. There can be probable risk of myocardial necrosis, which is attributed to sustained depolarization of the myocardium. They say it is more associated with the energy delivered rather than the number of shocks. Then thromboembolism can be there, especially in patients with atrial fibrillation with a prior left atrial appendage thrombus. So that needs to be kept in mind. And other complications which are not very common are pulmonary edema, transient hypertension, which is more sedation related, and cutaneous burns. So the important thing in relation to defibrillation is to know about this concept of double sequential defibrillation, because it is a high potential question that can be asked, and it was asked as one of the topics in the last exam. So in patients with VF or VT that is refractory to multiple defibrillation attempts can occur. So in such patients, double sequential external defibrillation that consists of rapid sequential shocks from two defibrillators can be done. So basically they say that two biphasic defibrillators and two sets of defibrillator pads are needed. So the pad for the pad placement, the first set of pads should be remain in the original position. That is one pad along the right upper sternal border and the second along the cardiac apex. And the second set of defib pads are placed. The anterior pad is placed on the precordium and the posterior pad is placed on the back in the left or right infrascapular region. So this is the vector change defibrillation placement mode. So in attempting double sequential defibrillation, it is recommended that two healthcare procedures each operate a single defibrillator device to ensure a intentional delay between the two administered shocks. But in the dose VF trial, which I'll discuss in the subsequent slide, they had said a single operator should be single operator was being used for using both the defibrillators. But in general, for better coordination, it's always better to have two healthcare providers providing defibrillation. The 2020 AHA guidelines, however, had said that defibrillation, double sequential defibrillation is not yet recommended for refractory shockable rhythms. But this dose VF trial had come in 2022, which is defibrillation strategy for refractory ventricular fibrillation. So on that, the clinical question was, in patients with refractory VF, does double sequential external fibrillation or vector change defibrillation, that is antero-posterior placement of the defib pads compared to standard defibrillation via anterolateral approach, improve survival to hospital discharge. So the intervention were vector change defibrillation, that is subsequent defibrillations were performed via antero-posterior pad placement. Double sequential external defibrillation, that is, like I mentioned in the previous slide, or single operator performed shock button on anterolateral followed immediately by antero-posterior defibrillation. So the external pads alone were placed and then defibrillatory shocks were delivered. Whereas the control was standard defibrillation, that is the pads were placed in the anterolateral position. And the primary outcome was time from survival to hospital discharge. So they found that it is significantly higher in DSED, that is double sequential external defibrillation, more than vector change, more than standard defibrillation. And secondary outcomes, they had seen that the ROSC was higher in ROSC, there is a return of spontaneous circulation was higher in the double sequential defibrillation than standard care, but vector change defibrillation didn't have any difference in compared to standard care. Whereas the termination of VF was higher in double sequential external defibrillation, more than vector change, more than standard defib. And survival with good neurological outcome was higher in the double sequential external defibrillation, more than vector change than standard care. So I think this is an important slide that needs to be kept in mind. The only limitation in relation to the study was it was terminated early because the sample size recruitment was a big concern because this study was done during the COVID era. So there was a poor recruitment. So the ultimate number of cases that were taken into consideration was low. But it had shown a good amount of it had good validity in relation to the outcomes. So coming to implantable cardioverter defibrillator, I'm just concentrating on this important aspects alone, not going in depth of it. So the indications is for secondary prevention of sudden cardiac death in patients with prior sustained VT or VF. In primary prevention of SED in patients with that's a primary prevention of sudden cardiac death in patients with increased risk of life-threatening VT or VF. That is in patients with diagnosed Brugada syndrome or etc. Whereas in AHA recommendations, they say that ASCD can be placed in patients with LV dysfunction with EF less than or equal to 35% with NYHA grade 2 to grade 3, or LV dysfunction with ejection fraction less than or equal to 40% with previous MI or at least 40 days post MI with inducible VT or VF on electrophysiological studies. So the main functions that can be done with this is ECG monitoring and storage can be done. Anti-tachycardia pacing, that is overdrive pacing can be done. Cardioversion and defibrillation can be done, or bradycardia pacing can also be done. The main contraindication to this is if the patient, if there is a reversible cause of VT and VF, this should not be implanted because it will further increase morbidity and cost. And the main components in relation to this is almost similar to that of a permanent pacemaker. There will be pacing and sensing electrodes, defibrillation electrodes, and a pulse generator. So coming to the complications, you have short term and long term. Short term are bleeding, thrombosis, pneumothorax, pain, pocket hematoma. Whittler syndrome can be there because of twisting and misplacement of the device and device-related infections. Whereas in the long term, there can be device-related pain, anxiety, lead fracture, inappropriate shock delivery, and device infection. So if at all during the practicals, they keep an X-ray of this, you will need to interpret it. So this is usually ACD device. Here you can see the leads that is being placed. And here there is an atrial electrode, and here there will be a ventricular electrode. So this is an important X-ray that can help you in identification. And here you can see that there is twisting of the leads. That is the Whittler syndrome. So the important thing is here you can see that the leads are getting twisted. So that can lead to malposition or malfunctioning of the electrodes. Thank you. So I think this covers my topics for CVS.